O God of creation, direct our noble cause, guide our leaders right, help our youth the truth to know, in love and honesty to grow, and living just and true, great lofty heights attain, build a nation where peace and justice shall reign. Amen. Please kindly have your seats. A round of applause, please, for everyone. Because at Farm Access Foundation and Nigerian Health Watch, we are very particular about timelines. We are very particular about ensuring we do things effectively and efficiently. We want to promise our audience today that as much as possible, we are going to stick to the time frames for each of the activities we have on our agenda today. So permit me to humbly welcome my amiable, beautiful, you know, when you say beauty and brains, my country director, who is a fantastic leader, a change agent within the healthcare space, not only in Nigeria, but in Africa and the world at large. I want to call her to give us her welcome address and remarks. As I call upon my country director, I would appreciate a resounding round of applause for Mrs. Njide Indili. You are welcome. A round of applause, please, for my country director. Thank you very much.
So good morning, all. Good morning. I know that we are usually late risers, or we always make an excuse, African time. But I think that as part of the change that we're looking for as a country, we need to start finding a way to adhering to times that we have, set for ourselves in terms of events and so on and so forth. So those that know me know that there's no African time. If you're coming late, you're coming at your own peril, and you miss the meat of the discussion. But anyway, having said that, I want to start by saying good morning and thank you to those who are here. My anchor, Buki, will come back and establish the appropriate protocols, but I must already acknowledge some of the people that are already here in the room, starting with Professor Sambo, who is the Director General of the National Health Insurance Agency. He walked in here at 9:30. So please, I think I would like us to acknowledge this is the kind of leadership that we're looking for. There are no flares. If you say 9:30, he shows up for 9:30. So thank you very much, sir, for being here on time. I also want to recognize Dr. Aribabuwo, who is the National President for HCPAN, the Healthcare Provider Association. Thank you, sir, for being here. Also a special thank you to my colleague who flew in from Ghana, Dr. Maxwell Antwi, who is the country director for Farm Access in Ghana. Thank you, Maxwell, for being here. And to acknowledge everybody else in the room. So today we are going to start on time and make sure that we don't hold you up longer than you need to be held up. Today is a special day in the sense that we as Farm Access, we have been supporting so many states in Nigeria towards achieving the mandate of universal health coverage. But we saw during COVID that the amount of money, especially donor funding that is coming into Nigeria, started to shrink because countries were, focusing on their own objectives. So our thought then was, how do we shift our focus to local resource mobilization? And that is how some of these discussions started. We started last year with some discussions in focus states like Kwara State, where we brought together even the Internal Revenue Service, we brought together Ministry of Finance, we brought together the Ministry of Health, so that they can start discussing amongst themselves and allocating appropriate funding for the healthcare sector. But then as my second cap as the Vice President of Healthcare Federation of Nigeria, We also then started discussions at the time internally, trying to find a way to mobilize resources locally. And looking at what other countries are doing, we collaborated with the World Bank as well as Nigeria Health Watch to begin a series of dialogues. We advocated for this sugar-sweetened beverage tax, which has now been implemented. So I must commend again the Minister of Finance for including this in the Health Act. But the discussion today is how do we ensure that we achieve the purpose, the original purpose of this tax, which is local resource mobilization towards the healthcare sector. So we understand that this fund is now being, the 10 naira per liter is being deducted, but it is not yet ring-fenced for health. So I think this is the anchor of our discussions today, which is why it's important that we have the right people in the room. Some of us are joining online. We also would like to welcome those who are joining us online. As of yesterday, we had over 450 people who had registered and will be joining us online. So we also appreciate you taking the time. So we're expecting the budget office to be here. They're not here yet. We also expect the Senate, the Senate Chairman on Health, Senator Loriebe, to be here. So we are hoping to have a really good discussion. Part of the output of this dialogue is to have a communique which will be shared with the Ministry of Finance, with the Ministry of Health, so that we can begin to work towards ring-fencing this tax as we're collecting it for health. So again, I want to say thank you very much. And I'm really looking forward to the dialogue and the discussions based on, experiences of our partners. So thank you once again, and I'll hand back over to Buki.
Thank you very much, Njide. I would also want to recognize the presence of the representative of the Embassy of the Netherlands here with us today, Mrs. Sonia Odije Fasujigbe. You are welcome, ma. A round of applause for her, please. As we move on the program, we keep recognizing more people as they come to join us on this program. We are moving fast to the next agenda to the next activity on the agenda. We are starting with our keynote remarks. So permit me to call on Professor Mohamed Nasir Sambo, who is the Director General of the Nigerian Health Insurance Authority, to give his keynote remarks. A round of applause for him, please. Sorry, my extension has just been called, sir. A little correction, sir. You can go back and take your seat. Yes, I'm so sorry for that. For the welcome address, we also have our Managing Director of Nigerian Health Watch, Mrs. Vivian Ihe Kweazu, who is going to give her welcome address and remarks virtually. So for people that are here with us and those that are joining online, she's going to give her welcome address virtually. So over to you, Mrs. Vivian. Thank you very much.
Thank you very much, Buki. I hope you can all hear me clearly. Can everybody hear me clearly before I continue? Okay, I assume you can all hear me. Yes, thank you ever so much. As Buki mentioned, my name is Vivian Ihekwazu. I am the Managing Director of Nigeria Health Watch. Thank you all ever so much for joining us this morning on this health financing policy dialogue. Thank you, Njide, for your intro. And as Njide mentioned, we've had over 400 people register so far. And as I've seen, we have well over 100 people already online, and we look forward to welcoming more people online. Please permit me to stand on the existing protocols established. As Buki mentioned, we'll be introducing more people as they come in. And I really thank our distinguished panelists and speakers who have taken the time this morning to join us on this really, really important health financing policy dialogue. We at Nigeria Health Watch are always happy and excited as always to be collaborating with Farm Access Foundation and the World Bank with support from the Healthcare Federation of Nigeria and of course, DGI Consult this morning. We've talked about health financing in many spheres, and at Nigeria Health Watch, this is absolutely one of those issues we have continuously pushed and advocated for. We all know how underfunded our health sector is, and the pot of money which we all use in Nigeria, the GBP, has not grown any further. And how do we expand that? It's been difficult. The fiscal space has been very tight. So really, this health financing policy dialogue comes at an extremely critical time in our country. Earlier this year, we were so excited and happy with the introduction of the 10 naira per litre excise tax on non-alcoholic drinks and sugar-sweetened beverages. But we know to date, the implementation has not been optimal. And so this is why this policy dialogue has come at a really critical time. Earlier this year, when the 10 naira excise tax was passed, Nigeria Health Watch, again, collaborating with World Bank, we held 3 pro-health tax webinar series, again, highlighting and pushing for the implementation of this very, very important pro-health tax. We all know the health consequences of the consumption of sugar-sweetened beverages, and we know that the implications on it leads to very negative outcomes in the way of non-communicable diseases, which I'm sure some of our speakers will discuss. So, this tax, it's coming again, I said, at a critical time, and we really are pushing for the earmarking of this tax for health. To date, we have never managed to reach the goal of the 15%. We know that's a very, very ambitious goal. So how else do we increase the funding that comes into the health sector? Our health is severely underfunded, as I mentioned. You can see this in the poor health outcomes and indices. Our maternal mortality figures remain extremely high. These are indices we are not proud of at all. Our primary healthcare system, which really should be the bedrock of any well-functioning health system, remains severely under-resourced and underfunded, with implications, again, for Nigerians in their access to healthcare. So, at Nigeria Health Watch, we feel it's been always very critical to advocate for these issues. And we've leveraged on all our existing platforms, co-hosting policy dialogues like this, working with stakeholders in the health sector and beyond to really, really push and advocate for more funding for health. With our sustained fund advocacy, it's been very important that we continue to bring the issue of health financing to the forefront, not really just for policymakers who really are at the forefront of pushing those levers that can lead to the change we need, but ordinary Nigerians. This is a very critical election year simultaneously. And why are we pushing for Nigerians to ensure that they have access to better healthcare? We also need to ensure that Nigerians, ordinary Nigerians who are on the receiving end of poor healthcare delivery, have access to better funded tertiary, primary health facilities and secondary health facilities. And the negative consequences of consumption of sugar-sweetened beverages, we see this in the rising incidences of NCDs like diabetes, which again come with a huge human and economic cost to families. So as I mentioned, with our very distinguished lineup of speakers who we're very happy to have here today, you will hear a lot of these discussions brought to the forefront. And the objective really today is to ensure that this SSB tax is earmarked for health. If we're not careful, it's very easy for it to disappear into other health sectors. As the government faces competing challenges of how to use the very limited funds that we have in the country. So we really need collectively, as CSOs, NGOs, development partners, collectively really to push for the earmarking of these funds to the health sector where it is urgently and desperately needed. At Nigeria Health Watch, we are happy to continue collaborating and partnering with organizations far and wide who will support us, and we will support them in the work that we're doing collectively to really push for a much better funded health sector. So thank you all for joining us today. We have a very busy program ahead of us. And with that, I will hand back to Kemi and Buki, who I think will now lead us through the welcoming remarks and some of our keynote speakers. So thank you, everybody, and over.
Thank you so much, Vivian. You have shared some very important insights there on how important this conversation is and how funds from the SSB tax can be earmarked for health. Thank you so much. So next, I'd like to acknowledge the presence of Mr. Ben Akabweze, who is the Director General of the Budget Office of the Federation at the Federal Ministry of Finance, Budget and National Planning. Thank you so much for being here, sir. Really looking forward to your keynote remarks. And I would also like to acknowledge the presence of Dr. Gafar Alawade, who is the Project Director at DGI Consults, one of our important partners for this event. So without further ado, I'd like to make welcome Professor Mohamed Nasir Sambo, who is the Director General at the National Health Insurance Authority. Apologies for the small mishap earlier, sir. Let's put our hands together for him as he gives the first keynote remark for this event.
The Director General Budget Office in the Federal Ministry of Budget and Federal Ministry of Finance, Budget and National Planning, the conveners ably presented here by Country Rep Palm Access, our sister Njide, my very good friend, Dr. Jimmy Aribaboa, President HESCPAN, Healthcare Providers Association of Nigeria, distinguished colleagues from Farm Access Ghana, other distinguished participants here present, ladies and gentlemen, members of the press, good morning. It gives me my immense pleasure to deliver this keynote remark at this highly auspicious event, the Health Financing Policy Dialogue 2022. I want to start by congratulating Palm Access Foundation, World Bank Group, Nigerian Health Watch, and other partners for organizing this forum, which brings together key stakeholders in the Nigerian health system, including governmental agencies, the legislature, the academia, the development partners, and civil society organizations. The importance of this event cannot be overemphasized. Nigeria was a signatory to Abuja Declaration, where African Union countries pledged to allocate at least 15% of their consolidated budget to health. But over the years, this annual budget provision has remained abysmally low, in direct violation of the Abuja Declaration. This year, only 5% of the budget was allocated to health, a far cry from 15%. This further underscores the urgent need for us to explore innovative and sustainable financing mechanisms. Any additional revenue that can be channeled to improve access to quality healthcare will go a long way to improve poor health indices and alleviating the suffering of many Nigerians. This platform is therefore an opportunity for us to come together to discuss innovative and alternative financing mechanisms that we can harness to channel towards healthcare financing that will help us to attain universal health coverage by the year 2030. The theme of this of Health Financing Policy Dialogue 2022, New Healthcare Financing Approaches in Nigeria, implementation of Sugar-Sweetened Beverage SSB tax in Nigeria, is very apt and also very timely. Excessive sugar consumption has been linked to a variety of healthcare problems, non-communicable diseases, especially diabetes mellitus, and dental caries. No responsible government will sit back and not make any effort to protect its citizens and regulating the intake of sugar unsweetened beverages can be indirectly be achieved by alleviating taxation to combat the rising prevalence of non-communicable diseases. According to the World Bank Group, in the last 25 years, there has been an almost 400% rise in the number of people living with diabetes mellitus in Nigeria. There has also been progressive increase in the prevalence of diabetes mellitus, with dramatic 2.6-fold increase in the prevalence over the past 3 decades, from a prevalence of 2.2% in 1992 to 6% in 2015. This means that the cost of treating diabetes has become an additional financial burden for affected individuals, their families, and the nation. The cost of treating mild to moderate diabetes ranges from 300,000 to 500,000 naira per annum. However, this cost can rise to millions in cases of diabetes with renal or vascular complications. This trend is particularly worrisome owing to the fact that, according to the National Bureau for Statistics, more than 82 million Nigerians live on less than $1 per day. Financial barriers, which include direct and indirect costs for health services, are major barriers to access to health care. Many Nigerians are struggling to feed. Countries that have attained universal health coverage are able to do so by prioritizing healthcare financing, especially through additional taxes or mandatory insurance. The Nigerian government on December 31, 2021, enacted a law that mandates the payment of an excise duty of 10 Nigerian naira per liter on all alcoholic and sweetened beverages in the country. The pro-health tax on SSBs will bring long-term benefit and healthcare cost savings through prevention of non-communicable diseases. The tax generated from SSBs will result in key outcomes, again for public health, by bringing about improved health outcomes and reduced healthcare costs. A plus for domestic revenue by introducing a new source of funding, and a win for the economy by the reduced loss in productivity due to ill health. The National Health Insurance Authority Act 2022, which has just been assented to by the President, specifically on the 19th May, is a revolutionary attempt to address the myriad healthcare financing problem that is affecting the nation. The National Health Insurance Scheme, just before this signing of this act, has embarked on various far-reaching reform to ensure that health insurance ecosystem is well positioned to be able to deliver the long-awaited universal health coverage. We have been able to develop a 10-year strategic plan that will enable us have a very clear roadmap to achieving that. We have digitalized our processes and developed a very overarching ICT system that can enable us deliver this. We have also developed a program known as GiftShip, Group Individual Family Social Health Insurance Program, that will enable informal sector to come into the National Health Insurance Authority. In the new revised or the new enacted act, a provision has been made that will enable National Health Insurance Scheme develop what is called vulnerable group funds. This vulnerable group funds is aimed to address about 83 million people that are living below poverty in Nigeria. on the very day of signing the law by Mr. President, he asserted that this law will be fully funded to achieve that. So this event that we are holding is one of the key conversation that will enable us to help Mr. President in fulfilling the mandate. So we are making a very strong case that channeling all part of the taxes from SSB into the Vulnerable Group Fund will help to improve access to quality health care for about 83 million people in the country who cannot afford to pay for the needed health services. Sugar and sweetened beverages affect health negatively, and therefore the proceeds from the taxation should be used to improve health. The most equitable way to provide access to health care is mandatory health insurance. Ladies and gentlemen, if you look at the healthcare delivery system, it can simply be divided into supply side and demand side. The supply side is a situation whereby you continue to develop physical infrastructure, physical facilities, deploy infrastructure, and also push in human resource. The demand side is ability to mobilize the people that are sick to go and seek the healthcare delivery services. But in a situation whereby out-of-pocket expenditure in the country is still hovering around 70%, then therefore the catastrophic healthcare expenditure is ensued in that country. So if we are to get our healthcare delivery system very right, we should shift the paradigm from substantially investing in supply side to substantially investment in demand side. Because the financing through the demand side can achieve what it can also be achieved in the supply side. What do we mean by this? When you prepare for healthcare for the people, the money that has been generated for the payment will eventually be in the healthcare facilities. And when the money is in that healthcare facility, it can be used in improving physical structure, it can be used in expanding infrastructure, and it can be used in addressing human resource. And it is the most efficient mechanism of healthcare financing as opposed to any other healthcare financing mechanism. So we are making a very strong case that the whole of these resources and other resources that we can leverage, like for example, 1 kobo per second call in telecommunication, can also be mobilized to come into the health insurance for the purpose of strategic purchasing. Yesterday, up to around 10:30 p.m., we were with Director of Budget and National Planning that is with us here today. We had a very lengthy debate, but I refuse to tell him that I'm also coming to this event, so that, and I refuse to tell him that I will be the one that will first speak in the event before him, so that before he make his own speech, I would have probably convinced him that this conversation will eventually gravitate into financing social health insurance. One of the key issues that Ministry of Finance is always trying to allude is the fact that there is competing needs. There is competing needs. Water Resources is looking for money. Ministry of Works will be looking for money. Ministry of Health will be looking for money. In public health, if there are competing demands, we develop a criteria for prioritization. For example, when we were teaching public health in the university, we say that, okay, if you have diseases, condition, malaria, upper respiratory tract infection, diabetes mellitus, how do you prioritize? Giving a limited resources, how do you prioritize? You cannot prioritize it using abstract, but you develop a criteria. In fact, we used to have many criteria for prioritization of disease, which include the burden of the disease, the social importance of the disease, the morbidity and mortality associated with the disease, the economic effect of the disease, and so on and so forth. So I want to crave the indulgence of Ministry of Budget and Finance to bring stakeholders. Let us do a prioritization as to where we will put into our money into it. It has been confirmed by the World Bank and other important literature that if you fail to invest in the healthcare delivery system, you will risk spending 10 times what you have ordinarily spent if you had done the investment. This is making a very strong case, investment case for the healthcare delivery system. So as we are moving, if anybody is in doubt that healthcare is in the top priority of the socio-economic development compact, we can sit down and do an academic debate. Let us develop a criteria for prioritization. And at the end of the day, we in the healthcare delivery system, we agree any sector that beats the healthcare delivery system, we will allow him to go with the money. And within the healthcare delivery system, we can narrow the debate between the supply side and the demand side. Whoever becomes first, we can allow the entire money to go into it. So the DG budget, thank you very much that you are here. I challenge the Ministry of Finance and Budget Planning to bring out criteria for prioritization so that it can robustly discuss and we know exactly where this money is going. And I bet you at the end of all the criteria, when you develop all the criteria, at the end of the day, social health insurance will take all these resources and many other more. With this remark, I want to thank you for listening, and I look forward for a very robust and fruitful deliberation during this dialogue. And at the end of the day, everybody will go back to his destination safely. Thank you, and God bless all of you.
Thank you so much, sir. That was really interesting. Really looking forward to the discussions around how the funds will be earmarked and all. Really happy that the National Health Insurance Act was finally signed into law. I'm happy about the Vulnerable Group Fund. So I'm actually really looking forward to the panel session and to Mr. Ben Akabueze's keynote remark, which comes next. But before I introduce him, I'd like to acknowledge some of our partners in the room. I'll start with Dr. Ngozi Azudo, who is joining us virtually. She is the Director of the Department of Health Planning, Research and Statistics at the Federal Ministry of Health, and she will be giving us a goodwill message later. Thank you so much for joining, ma'am. I'd also like to acknowledge the presence of Dr. Adila Khan, who is Maternal Health Advisor at the United Nations Population Fund, and is currently in the room. Thank you for being here. So without further ado, allow me to introduce the subject of Professor Mohamed Nasir Sambo's debates, Mr. Ben Akabueze, who is the Director General at the Budget Office of the Federation at the Federal Ministry of Finance, Budget and National Planning, for his keynote remarks, and hopefully for some responses to Professor Sambo's comments. Please let's put our hands together for him as he comes up to give his keynote speech.
Good
morning, everyone. And as we say in Nigeria, all protocols respectfully observed. It's my pleasure to be here with us this day. And yes, when I walked in and saw Professor Sambo seated, and as he said that we were together till late last night, and he didn't mention, I smelled a rat, and eventually the rat was let out of the bag. But it's indeed my pleasure to be here, and let me say up front that we are all on one side on this subject of improving health financing. But today, our specific focus is on the sugar and sweetened beverages tax, which in Nigeria was enacted by the Finance Act 2021, signed into law in January of this year. Section 17 of that law, the Finance Act 2021, provides as follows. That section 17 seeks to amend section 21 of the Customs, Excise, Tariffs, and so on Consolidation Act by inserting after section 2 a new subsection 3 which reads, so section 17 subsection 3 reads, excise duty on non-alcoholic carbonated and sweetened beverages shall be charged at a specific rate of 10 naira per liter. So this is the legal basis for this tax, and taxation is always a matter of law. At least 54 countries around the world have an SSB tax, 5 of them in Africa, with Nigeria being the latest. But the SSB tax in Nigeria, many may not be aware, was long in the making. It was first mooted in 2017 by the economic management team, was part of. But then the country was just emerging from a recession, the 2016/2017 recession. And so we determined that it was not the right time to do so. Up until that time, the greater imperative driving this was enhancement of government revenues. But of course, the connection with improving our health outcomes was not lost on the policy makers. In 2018, again, we reopened this. But at that time, Customs was challenged to come up with an estimate for what we were likely to realize in 2019 from this tax. And they came up with an estimate of 12 billion naira. And don't say I told you, but I think that some persons figured that 12 billion naira per annum was not worth the trouble, especially in the run-up to an election year. And so it was stepped down. Of course, immediately the industry got wind that we were thinking about an SSB tax. They mounted a strong pushback and lobby against the introduction of the SSB tax. And this continued even up until last year. But eventually, the tax was passed into law. And in our own case, as you heard when I read the provision in the Finance Act, it is to be charged as a specific excise tax on a volumetric basis at 10 naira per liter. Customs is still basically, dealing with the implementation, modalities. But when we debated this and discussed this tax, the thinking then was that the average pack size of SSBs in Nigeria is 33 cl, which means that if you're levying 10 naira per liter, then the consumers will be charged, 3.33 kobo per average pack size of SSBs, and so it was thought that the impact was not that significant. In practice, however, what we found is that consumers are being charged, the price increase on SSBs, the average pack size, which is often attributed to this tax, is higher than the actual incidence of the tax, which ought to be just 3.33 kobo per pack. Which recently I was at a health financing dialogue, organized by the World Bank in Washington, D.C., and some of my colleagues from other countries, in their own case, the industry was having a difficulty passing the tax on to consumers. In our own case, industry is passing more than the actual amount of tax on to consumers. So as we engage in dialogue on this matter, I think that this also has to focus on that, because that's what is going to then even limit the capacity to generate a whole lot of resources from this tax. Many have questioned the appropriateness of the tax, that's the SSB tax in Nigeria, on health grounds at this point, given Nigeria's relatively low per capita sugar consumption, currently estimated at 8 kilograms, compared to a global average of 36 kilograms and an extreme of 126 kilograms in the United States of America. However, there is ample evidence of upsurge in non-communicable diseases like diabetes in Nigeria, on top of our already very heavy communicable diseases burden. And we just heard Prof. Share the data on the incidence, the growth on in the incidence level of diabetes mellitus. And so, in any event, prevention is always better than cure. That's what those of you in health always say. And so we shouldn't wait to get to crisis level before taking necessary action. Some have also questioned the effectiveness of SSB tax in curtailing sugar consumption and the related health hazards. But here again, empirical data from some other countries indicate that SSB taxes can be effective in curtailing sugar consumption, including data from South Africa on our continent. Another criticism is that SSB taxes are regressive. This is possibly true, especially in the early stages of implementation before adjustments in consumption habits. But the tax burden on the poor consumers is, however, ultimately cheaper than the cost of managing any resultant health issues. While we have gone ahead, despite all of these objections, to introduce the SSB tax, we have stopped short of earmarking the tax to health-related expenditure. Until we get a clearer sense of its size, and also until the health sector demonstrates greater capacity to utilize resources allocated to it. As Professor Sambo stated, we need to have objective criteria for allocating our limited budgetary resources. And yes, we do. I urge you to check out our public investment management guidelines. It outlines the criteria on which we allocate, resources. Prof, let me caution you to be careful about what you ask for in terms of this debate, because everyone else has very strong case for why they should get more resources. You'll have those, for instance, who will argue that no matter how much you invest in health, if there are no roads to get the people to the place, to the healthcare facilities, then all your investment will amount to naught. There are those who argue that given that a significant proportion of our healthcare, our disease, burden is waterborne, that if you invest in clean water, you're likely to get, more bang for your bucks, as the Americans would say, than investing in a healthcare, facility. And the debate goes on and on. But we have a very tough job, especially when resources are as limited as they are for us. But for now, I urge us all to focus on effective implementation of the SSB tax. Let's bake the cake first, and then we'll come back to sit down and decide how to cut the cake. Thank you, and God bless you.
Well, thank you very much, sir, Mr. Ben Akabweze. It's really getting very interesting, right? We are happy this is happening, and we are sure that by the end of today's dialogue, we are going to have a very robust communique coming out that would ensure it balances every sector here. I want to permit me to kindly acknowledge the presence of some of our guests that are with us today. I want to appreciate and acknowledge the presence of Dr. Pamela Ajayi, who is joining us online. She's the president of the Healthcare Federation of Nigeria. I would also like to to acknowledge the presence of Dr. Olumide Okunlola, a senior health specialist at the World Bank. He's here with us in the hall. You are welcome, sir. And we look forward to your presentation later today. I would like to also acknowledge the presence of one of our special guests today. She's a woman of valor, very intelligent and hardworking. She flew in all the way from Kwara to ensure she attends this program today. She's the Executive Secretary of the Kwara State Health Insurance Agency, Dr. Olubunmi Jetawo Winter. You are welcome. A round of applause for her. We are moving on to the next activity on our agenda, which is the goodwill messages from representatives of the government, our donors, and private sector. And I would like to call on our first representative who will be giving us a goodwill message. She's joining us virtually. We have recognized that earlier on. She's the Director of Health Planning, Research and Statistics for the Federal Ministry of Health here in Abuja. So permit me to introduce to you again Dr. Ngozi Azodo for our goodwill message. Dr. Ngozi is online and she'll be giving our goodwill message now. Thank you.
Thank you, fellow participants at this very auspicious event. Good morning, and I want to stand on the already established protocol. I want to first start by acknowledging and appreciating the organizers of this event. The Health Watch never fails to, inspire and to lead. So we want to thank you very much. Unfortunately, you can't see me, my video, because I'm having internet issues here. So I shut down the video so that I can be heard. So I want to assume that everyone can hear me. Good morning.
Good morning, ma'am. We can hear you here.
Thank you very, very much. Thank you very much. The Goodwill message is simple, and it's once again to thank our Health Watch, who always leads and inspires. Thank you very much, Vivian. And by extension, thank you to Dr. Chikwe, who has been at the forefront of curating these matters. This is a very important meeting, and it's also very key to the activities of the Federal Ministry of Health. As we are aware, issues around consumption of products that are deleterious to human health is very, very key and impacts very seriously on the health of our people. So imposing taxes on such products is an evidence-based public health strategy to deter consumption. So we want to thank the Ministry of Finance, for spearheading this very important strategy. But we are the Federal Ministry of Health are keen to see that this strategy actually is used to impact public health. And as we all know, the non-communicable diseases are like the diseases of the future. When we take care of issues around the pandemic, around communicable diseases, the issues around non-communicable diseases are diseases that stay with us through a lifetime. And so we must begin to look at what we can do today to safeguard our health tomorrow. So products that like alcohol, tobacco, sugar-sweetened beverages, salts, and trans fats are the major causes of our health problems as we get older. And of course, for our younger children, because of the addiction and the marketing around it. So we think at the Federal Ministry of Health that it is important, and of course everyone agrees, which is why this where we are today, that it is important to tax this product and use them. In addition, we think that we must use the outcome or the taxes or the financing around this to deter consumption, not just for those of us who are older, but to stop our children, our young children, from consuming them, from forming the habits of deleterious consumptions early in life. And also to ensure that the damages already caused are taken care of. And that is why we ask that there should be earmarking of this fund to the health sector. We are working within the health sector, and we want to work with the Ministry of Budget and National Planning, especially through the Budget Office, to develop the criteria for support. We cannot have a prioritization of the utilization of the funds raised on account of these pro-health taxes without the guidance of the Federal Ministry of Health. So on behalf of the Minister of Health, who knows I am at this meeting, I want to request once again that we work with you to decide on the priorities on how to earmark these funds, on how to utilize this fund. The health sector is keen to get all of the funds, all of that, because we think that in addressing the issues of public health challenges around the consumption of addressing the public health issues around the consumption of these public health challenging product, we need to be mindful of the issues of prevention early in life. We need to be mindful of issues, addressing the issues of the challenges that have already arisen, and of course, building into the future to ensure that we do not have people get away with profit that can be avoided. So on that note, I want to thank the organizers of this event for inviting us. I am at the airport on my way to Canada, so I'm not able to join you physically. Dr. Uzoma will represent me at the panel discussion, and as much as possible, I will try to tune in online to participate in this conversation. Thank you once again, and God bless you. Good morning.
A round of applause for Dr. Ngozi Azodo. Thank you very much, Ma, for that goodwill message from the Federal Ministry of Health. Quickly, I'm moving on to call on the next individual to give a goodwill message on behalf of the Embassy of the Netherlands. Permit me to call on Mrs. Sonia Odije Fajusigbe for her goodwill message. A round of applause for her, please.
Good morning, everyone. Permit me to stand on existing protocols. Sincere apologies. The Consul General of the Kingdom of the Netherlands would have loved to be here, but is unavoidably absent, and I bring greetings to him, from him to everyone present here. First, we would like to thank the organizers of this event, World Bank, Farm Access Foundation, the Nigerian Health Watch policy, on this policy dialogue on healthcare financing approaches in Nigeria. Since 2007, the Netherlands government, through the Health Innovation Fund, has supported farm access to foster the development of an inclusive and equitable health systems. Some of the works that Farm Access Foundation has done through the Health Innovation Fund include strengthening of Nigerian healthcare markets, development of the private sector, capacity to ensure that improve access to quality healthcare for all groups, inclusive of low and middle income. In pursuit of the universal health coverage, 2030 remains a core objective. Some of the notable projects we've had since 2017, the first we have is in 2015, we had a market study health update, which basically was focused on identifying the gaps in the Nigerian health market and also to see areas of opportunities and collaboration between the Nigerian private sector and the Dutch life sciences and health private sector. In 2022, during the COVID pandemic, we also had some form of support to the Nigerian ecosystem, and that was in the form of the development of an app, which basically was useful to track the COVID-19 update and the impact. In 2022, we had the commissioning of an ongoing update for the market study, the healthcare market study, which basically is to identify opportunities and also see areas where we can facilitate partnership and collaboration between the Nigerian health sciences and the Netherlands health sciences. Farm access, to a large extent, has played a very great role, some of which is very, very commendable and include digital supports in terms of health financing, including the insurance mechanism, and also ensuring that the Nigerian health insurance scheme is decentralized to accommodate the growing population that we face. Some of the things they've also done is the quality care delivery, which is done through the safe healthcare, building the health services to be patient-centric and patient-focused, also mobilizing funds, funds, investment to ensure that there is an upgrade and need for investment into new healthcare infrastructure. The Medical Credit Fund is a good testimony of that, and have been to several events where we have seen different health facilities thriving on that. A very good example to also commend Farm Access, and which is also part of the things we do, is part of the Dutch government-funded Health Innovation Fund, is how we've seen that there can also be a transition and a change in the healthcare system, especially the primary healthcare delivery system, which is the major point of call in healthcare before you get into the secondary and tertiary healthcare system. We've seen also that pharmacists has also supported in terms of strategic, independent, and scientific evidence research and advocacy to support the healthcare development in Nigeria. We must, on behalf of the Consul General, we must recognize and applaud the recent National Health Insurance Act 2022, which was passed by President Muhammadu Buhari. We know that I must state this categorically, that the Health Innovation Fund and Farm Access played a very, very pivotal role in terms of advocacy and supporting and ensuring that the acts were signed into law. We also commend the provision of the basic health provision fund, which is focused basically to supporting the insurance premiums, as mentioned by Professor Sambo earlier, to ensure that an estimated 83 million Nigerians who cannot afford health insurance are covered, and the indigent, especially vulnerable women and children, are part of this. Nigeria remains a priority country for the Netherlands, and also healthcare is one of our priority sectors, inclusive of agriculture. At the moment, Nigeria is a focus for our top sector, life sciences and health, and we're happy to mention and to state that to further consolidate on the gains and the progress that Nigeria and the Netherlands has made in the last 10 to 12 years, we have identified opportunities, and as a result of this, we'll be embarking on a healthcare fact-finding mission in Q3 2022, comprising of both private sector and public sector. We know, and we would also like to state that building a strong, inclusive, and accessible quality healthcare system is fundamental to strong economic growth and productivity in Nigeria. The Netherlands Consul General, Mr. Michel Dillon, assures you of his highest regards and wishes you all a fruitful deliberation. Thank you very much. Thank you.
Thank you, Mrs. Sonia, for your beautiful goodwill message, and of course, again emphasizing the mission of farm access in Nigeria towards ensuring making health markets work through our innovative mechanisms, innovative solutions to catalyze practical changes. Please, I have an important announcement to make for those online and for us that we are here in the hall, that we should kindly mute our systems so that we do not have too much interference. I want to call on the next individual that will be giving a goodwill message. I want to call on Dr. Pamela Ajayi, who is also joining us virtually. She's the president of the Healthcare Federation of Nigeria. We call on her now with due respect for our goodwill message. A round of applause for her, please.
Thank you. Thank you very much. I hope you were able to hear me. I'd like to offer my sincere regrets for not being able to be actually with you in person. Please permit me to stand on existing protocols. As President of the Healthcare Federation of Nigeria, I am honored to be here and really want to strongly commend Farm Access, Nigeria Health Watch, and the World Bank for convening this very important meeting. HFN has always been a strong proponent for the implementation of the pro-health taxes. And in addition to working with our partners, Farm Access, Health Watch, and the World Bank, I'd also want to point out to our previous speaker, Mr. Ben Akabueze, that we actually actively worked over the past years or so on convincing industry about the importance of the sin tax, the SSB tax, and why it was important for healthcare. We also wrote to the Minister of Finance, pushing for these taxes to be used in healthcare to provide coverage for the indigent populations and to scale up the mandatory health insurance coverage for all. And, requesting that these taxes are earmarked or ring-fenced for specific health impact-related schemes, as well as research and development. And now that these taxes have been implemented, we at the HFN are making a clarion call on behalf of the people, calling for the support of this process to ensure that this opportunity for us to bridge the gap in the funding of healthcare in Nigeria is not lost. We stand with Professor Sambo and also Dr. Azodo and all the others who are here and want to make this strong appeal and urge the Ministry of Finance and Budget to really assist us. We feel that this move, if it is consolidated, can move us significantly towards achieving our SDG goals of universal health coverage and also the Abuja Declaration. The words ring fencing and earmarking mean the same thing, ensuring these funds are used and kept for a specific purpose. It is imperative that we put in place the legal framework to secure these funds, and really we need to leave this meeting with an agreement on this goal. And if necessary, setting up committees, obviously with the Federal Ministry of Health, to ensure that these guidelines are worked out, and as she mentioned, the criteria are set up for equitable and sustainable disbursement of these funds. We want to once again strongly appreciate the convenience of this meeting, the Farm Access, the World Bank and Nigerian Health Watch, and wish you a successful deliberation. Thank you very much.
Thank you very much, Dr. Pamela, for your goodwill message. As we were going on through the program, we have in our midst a delegation from WHO Geneva. And I would like to acknowledge the presence of Dr. Kutsen and his team. You're welcome. Who will also be giving us a goodwill message later in due course. I would like to call on our colleague from Ghana, who is the country director for Farm Access in Ghana, Dr. Maxwell Antewi, for his goodwill message. Maxwell, you have the stage. Thank you.
Well, good morning. Oh, I said good morning. Thank you. Ladies and gentlemen, let me stand on existing protocols respectfully. I bring you warm compliments from Farm Access in Ghana and also Healthcare Federation of Ghana. My sincere pleasure also to join you for today's health financing policy dialogue with a focus on the new health financing approaches in Nigeria linked to the implementation of the Sugar-Sweetened beverage tax. This dialogue, ladies and gentlemen, is meant to provide a thorough review and consensus on health financing strategy for Nigeria for actual pragmatic implementation, but also to inject some new energies into achieving Nigeria's identified UHC 2030 priorities. Ladies and gentlemen, permit me to briefly share with you some learnings and insights Ghana has gained on its health financing journey, which are critical for today's dialogue. After all, our late President Nnamdi Azikiwe and Kwame Nkrumah, both of blessed memory, were very good friends. And it is generally accepted, at least in Ghana, that Nigeria and Ghana have intertwined national destinies. So Ghana started with a free healthcare policy in the 1960s and 70s, which were fully funded by the government budget. We later transitioned in the 1990s to user fee, which we popularly called cash and carry. I remember then as a young medical officer, when somebody comes in an emergency room, the first you do is to search their pocket or their bag if they had any money on them. Then we transitioned to piloting of community-based health insurance schemes, mainly by church denominations in the 1990s. And then about 20 years ago, a countrywide national health insurance scheme was bequeathed to us by our former president, John Ajekun Kufuor. At Farm Access, we have been working actively with the Ghana's National Health Insurance Scheme since 2008 on the development of accreditation, or what sometimes we call credentialing standards for healthcare providers, the linkage of Ghana's National Health Insurance Card to Ghana's biometric national identification card, so that people who are holding the national ID card, which is the ECOWAS card, and incidentally, when I got to the airport yesterday and they asked me for my ECOWAS card, that same ECOWAS card can be used to access national health insurance services without having to go for another biometric registration for an NHIS card. Also, we have worked with the National Health Insurance Scheme in poverty mapping and identification of indigents so that they can be exempted from premium payments. We've been working also with them on digitalization of enrollment and re-enrollment of members, but also importantly, a digitalization of claims management. Ladies and gentlemen, over the last 2 years, we have been working actively with Ghana's National Health Insurance Scheme on big data analytics, leading to 3 major policy interventions in unison with other partners, some of which are represented here. Let me acknowledge my good friend from WHO. I'm sitting on my left side. Ada, you're welcome. Good. So this has led to 3 major policy interventions. One of them is the revision of Ghana's national NCD policy, which was launched by His Excellency the President about a year ago. The second biggest revision is the inclusion of family planning in Ghana's national health insurance schemes benefits package. And the third is the inclusion of 4 childhood cancers in the NHIS benefits package. And all these were out of the result of the actuarial modeling and the big data analytics that we and other partners worked with Ghana's National Health Insurance Scheme on. Briefly, Ghana has a population of 31 million, as most of you know. Our GDP per capita is about United States dollars of 2,000. Life expectancy for females in Ghana is 64. Most men are not supposed to live long after their retirement, so we are around 63 thereabouts. Current health expenditure per capita is about $75 US. Domestic government expenditure is about 40%. Dr. Sambo, out-of-pocket expenditure is around 36% of current health expenditure, and external expenditure as a percentage of current health expenditure about 10%. In summary, Ghana's current health expenditure is mostly domestically financed. Ghana's NHI has some very interesting features. So current active membership is about 54% of the population, and I mean current active members. It's about 54% of the population. The funding comprises of 3 models which work in combination. So the first is the Beverage model, which is 2.5% consumption tax, not only on sweetened beverages, but on goods and services, and very few goods and services are exempted. So generally, it's a very broad-based tax. The second model that works with the first one is what we usually call the technicians call the Bismarckian model, which is 2.5% of pension contributions, and it is deducted from payroll as source for both formal, private, and public sector workers. And the third combination is the mutual health scheme model, where graduated premiums are paid. Generally now it's about $5 US for those in the informal sector. However, the consumption tax and the pension contributions currently, as at end of June this year, constitute about 95% of the total inflows, which means that only about 4 to 5% currently comes from payment of premiums. Ladies and gentlemen, in Ghana's healthcare financing journey, we have made some progress. We have also made some mistakes. Permit me to share with you some of those mistakes and progress in the hope that Nigeria will do better where we failed. So the first is Ghana's lesson number 1. Political will is sine qua non for a good health financing strategy. So ladies and gentlemen, political will, if used well, can transform Nigeria's health financing strategy for a common national good. In Ghana, in the year 2000, the then presidential candidate, John Ejekun Kufuor, who had lost a previous presidential bid, promised to give Ghana a national health insurance scheme if voted into office. When he won the elections, he introduced a value-added tax of 2.5% on goods and services to finance health insurance in Ghana, even though, ladies and gentlemen, he was the leader of a political party that had vehemently opposed the introduction of VAT whilst in opposition through a public demonstration that turned violent. And I see my friend Ghanaian laughing because he can remember it, but that demonstration was called Kumipraku. Kumipraku means kill me anyway. and indeed some were killed. However, in office, he used his political will against the stand of his political party for a common national good. And now in his old age, he is labeled as one of Ghana's greatest and a living national hero. So the SSB tax will require some strong political will to be deployed for common good to realize the intended benefits for Nigerians. And I hope our political leaders who are listening will rise to the occasion. Ghana's lesson number 2, earmark the tax for sustainable health financing. So Ghana's national health insurance levy is earmarked for financing NHIS. And Joe Kutin is very familiar with that as he has been engaged on this for a long time. In the first 3 years of implementation, the NHIS actually had surpluses of unspent funds. Currently, 95% of the NHIS annual budget is financed through tax on goods and services and pension contributions. So this really creates a dedicated stream of financing and a relatively stable income required for implementing long-term health financing strategy for the benefit of residents in Ghana. So there's a good reason to really, and I was listening to the Director General for Budgeting, there's a good reason to really work together to earmark this SSB tax for health. And I hope this dialogue will not shy away from that discussion, as Professor Sambo has already sounded the alarm bells for all of us. Ghana's lesson number 3, the last I would mention, beyond earmarking, please ring fence who is the spender of the tax. So Ghana is currently lagging behind on claims money payment for about 6 to 8 months. Ladies and gentlemen, in 2016, this delay in reimbursement was nearly 18 months behind schedule. So the question is, if 95% of the NHIS budget is financed through dedicated earmarked funding, why the delay in paying claims to providers? We have learned, ladies and gentlemen, that it is not enough to define how the money comes in. In this case, the SSB tax. Neither is it enough to define what the money should be used for. In this case, earmarking the SSB tax. Please also work on who is the spending office. We are wiser now than we were 20 years ago. In Ghana, the NHIS spending office is the Ministry of Health, Ministry of Finance, Our experience across different political administrations is that when the NHIS consumption tax revenue comes into the so-called consolidated fund, I call it the big melting pot at Ministry of Finance, it loses its identity as an earmarked tax. It's a melting pot. And the NHIS does not get all of that money back. The Ministry of Finance legitimately has competing needs and sometimes may use the earmarked funds for other legitimate competing national needs, as the Director General of Budget has mentioned to us this morning. So Ghana's NHIS averagely receives about 50 to 60% of what they should have received on paper annually as earmarked funds. I trust that this health financing dialogue will actually translate to tangible improvements in the health indicators for Nigeria, especially for vulnerable persons and our comrade Nigerians who are of low socioeconomic status. So beyond earmarking, please ring fence. Beyond ring fencing, please work a bit on designating the right spending office. Once again, on behalf of Farm Assets Ghana and Healthcare Federation of Ghana, kindly accept my sincere compliments.
Thank you so much, Dr. Anthony, for sharing lessons from Ghana. We also consider Ghana, our brothers, except on the matter of whose jollof is better, because, no one can win that war. So very quickly, I'd like to acknowledge the presence of the WHO Healthcare Financing Mission in Nigeria. My colleague already mentioned it earlier, but I'd like to specifically recognize the presence of Dr. Joseph Douglas Kutsin, who is the coordinator of health financing and governance and is the head of this delegation at WHO Geneva. And the rest of his team, Dr. Juliet Nabionga, a medical officer and head of health financing at WHO Afro, Fadi Dikmi, I hope I got that right. The Technical Officer, Health Financing at WHO, Afro. Kingsley Adai Frimpong, Technical Officer, Health Financing, WHO, Afro. And Dr. Francis Nwanchukwu Ukwije, who is Technical Officer for Health at WHO Nigeria. So very quickly, let's welcome Dr. Joseph Douglas Kutsin for a goodwill message this morning. Please put your hands together for him.
Thank you. It's very nice to be here, and this is an assignment given on short notice. The risk is, as always, if anyone knows me, that I will talk too long, but I'll try to be brief. First, I'm very pleased that this is the subject of this meeting. In WHO, we're very strong supporters of health taxes, and really, as an economist, there's a fundamental rationale for dealing with the harms that the consumption of certain products do, right? So in this case, sugar-sweetened beverages, their contribution to NCDs, and so on. So in a way, raising the price of this actually really aligns the cost with the benefits in that sense. And oftentimes there's scope to increase these taxes more. And I've been in meetings with even the head of fiscal affairs at the IMF, and they're also quite strong supporters of the taxes on sugar-sweetened beverages and the additional agenda here, right, on tobacco, on alcohol as well, which I know politically has not been possible to move on here. But these are very highly cost-effective health interventions. I'll come to revenues in a second, but the main rationale for these taxes is their health benefits, right? And we can think of it both in terms of health in the short run, but when we're also thinking about universal coverage and thinking about concerns with financial protection, then the more people who have an NCD, who have hypertension or diabetes and so on, the more difficult it's going to be in the future to really pool funds and redistribute to the need. That basically it's going to be a much higher cost population to serve. So these types of interventions have important implications long run for your ability to sustain progress towards universal coverage. And again, I really want to appreciate the work of the government to take on this politically challenging agenda, because I'm sure, as you experienced, when you take on the health taxes agenda, you bring out a lot of opposition that has to be faced as well. So this is really a commendable step. On the revenue side, there is a lot of debate around the earmarking issue. Most public finance people will tell you that they don't like earmarking because government needs to be free to assign the revenues as needed. What's critical in health financing is, regardless of the tax source, that the purchasing agency, and now as we're coming in with the NHIA and the state health insurance agencies and so on, they need a predictable and stable flow of resources that gives the opportunity then to enter into meaningful contracts with providers that can then be executed. So whether or not the tax is earmarked, the revenues need to be dedicated for this purpose, and whether those are coming from general budgets or these taxes is less critical. Maxwell mentioned the example of Ghana with the earmarked VAT for health insurance, and it's true that in the first few years, this led to an increase, a much needed increase in the revenues. But over time, the government was basically and did reallocate discretionary revenues away from health. And now, many years later, the share of government spending going to health is actually less than it was before the tax. So the message that I want to give on the revenue side is that while the tax is very important, and while it's important to make the case, if finance is open to it, to make the case for earmarking, don't let the dialogue with finance be limited to this one tax. It needs to be comprehensive, okay? Because there is, and the evidence is clear, there is fungibility in the longer run, right? So this is the revenue side of the message, is to focus on getting these taxes passed, but have a broader dialogue with finance on the revenues. And finally, and as was said, and I'm sure this came, although we weren't here yet, from the DG budget, that ultimately the credibility of the sector depends on effective spending. And again, the NHIA becomes a key player in this process. That one saying we have in health financing is that you can't simply spend your way to UHC, right? So while the revenues matter, it's the effective use of the revenues that's most critical and builds a momentum and confidence in the budgetary authorities to then increase your budget because you demonstrate that you can use the money effectively. So this is really the challenge that lies ahead. From what I've seen in a very short visit, you're in very good hands with the leadership of the NHIA, and we're fully supportive of this agenda. And so I wish you well in the discussions today, and looking forward to hearing the presentations and the dialogue. So thanks very much.
Thank you so much, Dr. Kutzing, for your goodwill remarks. While you were speaking, we had someone important enter into the room, Dr. Ibrahim Yahaya Oluriegbe, who is the chairman of the Senate Committee on Health, and will be giving us his keynote remarks. Please put your hands together for Dr. Oluriegbe for his keynote remarks.
In line with the Nigerian culture and tradition, let me say I align with the established protocol, which I'm sure will have been established since the beginning of this program. And let me apologize profusely for coming in late. I think it's a mix-up in my program. This program was not scheduled as part of my program today, so I had another program I had to do earlier. So my apology. Otherwise, I gave my commitment. But I'm very pleased to be here, but I feel a little bit concerned. I wasn't here when some of the earlier speakers have spoken. So I will seek your indulgence and apology in case I repeat anything someone will have said before I come. But they often said, the more it's repeated, the probability that stays better and the probability to have better effect. I thank the organizers for inviting me to be part of this very important dialogue, especially at this time, because it's a period where we are in the process of processing another budget for next year. But I'm saying that because, just like the last speaker said, and I'm sure I was told that the DG budget is here, it's one of those that always said any tax collected cannot be a mark for a specific sector. That must go to the pool, and it's from the pool they will pick it up. I saw Dr. Olumide. I know when we were struggling sometimes 2021 to get this tax be incorporated into the system. We were thinking it as something that would be a mark. It used to be called sin tax, but now we said there's a different name that they give it. But I'm starting from the one that's sugar-sweetened beverage. It wasn't the only tax that was proposed. There was proposal for tax on other activities or engagement that impact on health, such as alcohol, just like the last speaker said, tobacco and so on. But what I want to say is that the first thing that is there with some of these taxes is the challenges with collection, and especially with the payer complaining that they are taxed in multiple ways. And two, we are all aware in this country of the struggle around the value-added tax and the issue of our federalism as to who is to collect or not. Some of these products that want to tax are products that are produced by factories and so on located in some places in Nigeria. So Nigeria is different from many other countries where
You cannot just say you want to collect tax. State will look at certain laws and say, no, federal cannot collect this tax. It must be state that will collect and utilize it. But having said that, I'm sure our concern here will be, one, how does it benefit health? How do we utilize it to be able to increase the delivery of the services required to improve on access, both physically as well as financially, in terms of preventing financial catastrophe at the point of seeking access? Because it's one thing to have the money, it's another thing to how do we use the money. So as such, I look forward to the panel discussions to be able to see how this will be. But I want to come up with experiences that we've had. And as somebody that is privileged to be in the SADU now, I'm sure the DG budget must have mentioned this. It is sad to say that in the sector, particularly in this the last budget, 2021 budget, the health sector returned money back to Treasury, unused money, as high as almost 6 billion naira. This is sad. So it shows that the absorption capacity or the efficiency in terms of utilization is very poor. If that is happening, why are we asking for more? So as such, I know we have broad range of stakeholders here. I was representing Federal Ministry of Health. The minister is not here. If he's here, because I'm not happy about that. As oversight arm of the government, we put our pressure and we did actually try to see, and we were willing and ready to be able to repurpose the fund for it to be used. But the minister himself was not willing. This is in public domain. Because the funds were already appropriated. Appropriation is a law to say use this for this. If you don't use it, except the parliament reappropriated, you can't. But we were willing, but the ministry is not willing to do its own part to be able to get this money utilized. And this will affect whatever tax you are collecting. If you're asking for more from finance, finance will say, what we are giving you, you are not utilizing it. So that's number one, but that's overall. Number two is about the allocation of the resources itself at the federal level. Because when budget is made, if you look at the budget, the Federal Ministry of Health wants to take large proportion of the federal budget in the ministry. Whereas the services are not in the ministry, even for the responsibility that are given to federal government, which is tertiary care. Proportionally, what goes to the delivering agencies of Federal Ministry of Health is usually lower. It is only when the budget comes to the National Assembly that we try to repurpose and reorganize to shift more resources to these agencies so that we can have more things done at that level. This is an issue because I'm saying this, unfortunately, I won't be part of the distance, but let's hope those that are coming, we still retain this. Because if the allocation from the executive itself continue to be like that, there will always be challenge. And there must be a discussion to be able to say, in terms of allocation, are we allocating based on need, not just based on power? What I say power now is that it is the ministry that sits and say this is the pot of money for this sector, for our sector. So the ministry will do this. The finance should be able to be challenging this more to enable that to go. But having said that again, in terms of when we say we get taxes, except now, for us, except we now try to see that we are allocating based on the processes of purchasing health. Because now, when this money is collected, whatever is the tax, it goes to the sector. NHIA may not benefit from it, except if it is specifically said now we are directing it into the vulnerable group fund. Because NHIA as it is now is not funded by any other means other than the basic healthcare provision fund, to be able, and whatever it generates, what it gets from premium pay based on the quarantine. It's only the vulnerable group fund. And of course, the vulnerable group fund, the only thing we have there now is that we should, the executive or the government should allocate, and then National Assembly will appropriate the proportion of funds. So we need to be able to have dialogue and discussion with finance to get resources allocated towards that. Because for us to achieve universal health coverage, we have to look at that demand side through the NHIA to be able to get more resources going to that. And finally, I know we are only looking at this tax. I think we have to put on the front burner the issue of what we wanted to get from the original NHIA, which is the taxing communication, telecommunication. Recently, the last few weeks, I was in Saudi Arabia, and I saw how much of tax is placed on telecommunication there. If you buy, it is 15%. If you buy 100, let me say 100 naira airtime, you pay 115. You pay 15 on top of it. You buy 50, you pay something like it is almost 650 something. It's 57 or something like that you have to pay on top of it, and so on and so forth. You buy 30, it's 35. So I don't know how they use their resources, but I think in this country also, rather than all this, it looks to be an untapped tax that we need to look at, because everybody utilizes that. Either you are poor, you are rich. It's like it's based on your earning. We have experts, finance experts here. This one may be consumption, but it's easy. It's difficult to be able to calculate, to do all those things. But that one, just like what I said, it's simple. I was looking at it from that perspective. I've been in that country several years, many years before. It wasn't like that. But now it means they are collecting huge amount. Of course, it's a country that has a lot of people going. In Nigeria also, that means either you are a resident or you are a visitor. Once you come, you will use that, you pay. Only God knows how many billions in their currency they will have collected in those 3 weeks of massive number of people entering their country. And they'll be able to use it to do better. But for us, if we want to fund health better, beyond this sugar-sweetened beverage and other syntax, I think we should still continue to demand and get that communication tax. The new thinking I'm having about that, to be able to negotiate finance, is that even if we are not going to keep the whole money, we can start to earmark a proportion of it to say it will be ring-fenced for health, so that the vulnerable group fund will build in such a way that we have enough to be able to address our healthcare. Thank you very much for inviting me. God bless.
Thank you so much, sir. You have given us a lot to think about as we, chart the course for implementation of the sugar-sweetened beverages tax. So a small amendment to the agenda. Just before we break for tea, I'd like to make welcome Dr. Olumide Okwala, who is the Senior Health Specialist at World Bank, for a presentation on an overview of implementation of the sugar-sweetened beverage tax in other countries.
Thank you. So, coming after the Chairman Senate Committee on Health and some of the salient points that he has made, in fact, it pales in significance to whatever I'm going to say. Because if we stand here and advocate for more resources, and then you have a sector that is also returning funds, and we say and we write that Nigeria spends so little on health, then sometimes you wonder how you situate that within that kind of context. The DG Budget, who just left, mentioned that he met with Professor Sambo and the NHIS team till almost 10 p.m. last night. The conversation was more about how do we raise more money for health. So how do you then marry the two issues together? Please, can we have the presentation on, please? So essentially, I'm going to be saying 4 things. So how does this work? Please. Sorry, how does this work? Okay. Anyway, next slide. Next slide, please. Okay, bottom line, the key message here is that we're not, as a country, we're not raising enough money. But beyond that, it's what you raise that you'll be able to spend. We're also not spending enough because you don't have enough, to the extent that Nigeria is perhaps one of the, next slide, because out of a data set here, where in terms of revenue raising compared to the size of the country, we're 115 out of 115. And a similar conclusion can also be deducted from the expenditure side of things, based on the size of the economy. And this is important within the framework of, if there's something we know, no country can achieve universal health coverage without public financing. So if the amount of money you are raising, it certainly doesn't meet the par, then you're going to have challenges on your UHC journey. And I think it's just important to situate this. Next slide, please. And this is the framework or the breakdown of how such revenues are raised across all tiers of government. But I won't take you through all of that at this point. But I just wanted you to begin to see where exactly this money is coming from. Because if the dark blue line there shows the amount of money that is shared by FEC and through the federal allocation FAC disbursements. And that blue section is going to shrink significantly in the next couple of months. It's shrunk already, and that will have implications for social services. But the good news in all of this is that there's actually a lot of money that Nigeria is leaving on the table. And what this represents is that if you say that for a country to achieve universal health coverage, it needs to achieve a tax to GDP ratio of about 15%. And Nigeria, as at 2021, is at 8%. This is the kind of volume, almost $50 billion, that we are leaving on the table. So this is potential revenues that we should be collecting that we're not collecting. So that's a good news in terms of if we strengthen our tax collecting efforts, there is probably a lot of money that is available for us to fill the gap that I mentioned. But also very quickly, I needed to bring all of this up front so that we are able to put our case on a solid footing. So the number of poor and vulnerable Nigerians is rising by the day. And two key factors are responsible and I'm not even talking COVID. But if you add COVID, if you add the war in Ukraine, if you add inflation, which is at 17%, the highest on the continent today, between last year and early next year, you're going to have an additional 10 million Nigerians living below the poverty line. So in other words, you're going to have about 91, 95 million Nigerians in poverty. So we're not raising revenue. There's a potential to raise more, but people are getting poorer. And number 4, states, because of what I shared earlier on, would have less money to share from the FAC account. Services are delivered at the state level. So the first thing that will suffer at the state level will be the social sectors, health and education. So it means then that the kind of grants that the federal government allocates to states becomes very important. So it means if the federal government is able to raise more revenues so that additional federal grants, the BHCPF, the FAC allocation, states will get more. So important to have a good understanding on the revenue side. And that's why I try to bring this up, so that as health advocates, we can situate our arguments on solid ground. The other argument for SSB taxes will be, primarily, this is a health tax. Revenue is secondary. Because at the end of the day, as a sector, we will be the one to bear the brunt of the consequences of the complications of this consumption of sugar-sweetened beverages. I think many speakers already have alluded to the fact that there's a rising incidence and prevalence of diabetes mellitus, but that's only just a tip of the iceberg. As this, I'm trying to go back, please. I wanted to share. Anyway, essentially, I wanted us to define what sugar-sweetened beverages are. It's important because the Finance Act indicated, and I will want you to go back to it, indicated carbonated tax. If you stricto sensu look at the tax from the perspective of carbonated taxes, then you'll be leaving a lot of money on the table. So it's important to have a solid definition of what sugar-sweetened beverages are. Otherwise, you will leave all these energy drinks, amongst other things, on the table. And those are the kind of things that industry is now using to want to try and circumvent this law. Please, this is not, it's actually frustrating me. Next slide, yes. So essentially, we have carbonated drinks, lemonades, enhanced waters. So sometimes you see something in the supermarket, it's like a water, but it's flavored. That is a sugar-sweetened beverage as well. Oh, damn. So just to point out that the DG quoted a figure. That figure is from industry in terms of the sugar consumption per capita. That's not what the evidence is saying, but I bring this up because it means that for us in this room, we need to be ready to present to Ministry of Finance and Budget hard data based from or data curated from global evidence, backed by global evidence. Because when he said that Nigeria consumes 8 kg per capita, I think that was his word, that's not what we have here. But what we are seeing is that Nigeria has the 7th highest per capita consumption of carbonated soft drinks globally. And this directly correlates to the consequences in terms of non-communicable diseases. But bottom line is that we know that these taxes are modifiable. Thankfully for that. And that's why we want to use the instrument of taxation to modify that risk. And let me say that because that is our primary objective, we want to modify that behavior. It then means that the level of taxation must be significant enough to change behavior. So at the current rate of 10 naira, it's almost not worth your time instituting the tax. Because what industry will do is absorb it and keep price constant. So the figure again that the DG budget mentioned, based on the current rate, might not be necessarily correct, and that's where we also need to help to say if you, right now, that 10 naira per liter is perhaps one of the lowest in the world. We are glad that at least that opportunity has been created. But the next phase of our discussion, so if there is one ask to this audience is, thank you that you've instituted the SSB tax, but please let's begin to tax appropriately. so that it can deter or modify behavior. That will be a key ask from this audience. So essentially several countries across the world, and these are some of the countries, but it's probably also important to situate this discussion within, I hear what Dr. Kudzin mentioned, and also Senator Luriak, but maybe as a stakeholder group, we should not focus necessarily on SSB taxes alone. Perhaps what we should be considering is look at the entirety of pro-health taxes, which will be alcohol, tobacco, and sugar. So Nigeria had introduced or increased the tax rates for alcohol and tobacco in 2018. It was meant to be a phased graduation of those particular taxes. SSB was the new one. It hadn't been introduced before. It was only just introduced last year. But alcohol and tobacco were meant to be increased over time. But industry pushed back, meaning that phased graduation is not happening. Meaning you are leaving money on the table. First for your pot, which translates to the health sector somehow. But if you then follow through, this is my second ask, which is let's do this advocacy looking at the entirety of SSB, alcohol and tobacco, then we're talking of a larger and bigger pot of money for the sector. So just to mention that Philippines was able, you cannot talk about the universal health coverage story of the Philippines without talking of the health tax law or the sin tax law in Philippines. It was a hard battle, but it was a battle that translated straight away into universal health coverage in the Philippines. And I urge you to just get a bit more background about that. But there's one thing I'd like to highlight about the Philippines. So you had an output-oriented framework. And I think this is really where we should begin to situate our earmarking story, so that we don't have the kind of stories where money is sent to the Federal Ministry of Health, and like the distinguished senator has said, the ministry is unable to use it and then it's sent back. Max, you can see that this is a better problem to have than in Ghana, where the money is lost inside the port. And now, what I think needs to happen, distinguished senator sir, is that when the money is in the port, let there be a conversation between Ministry of Finance and Ministry of Health, like the Filipinos have done, to say, we are giving this money this year to 20 million poor households. We're giving this money to 10 or 50, whatever money it is. So every year there's an agreement that this is the number of households that will be financed. And we have two opportunities to do this. The BHCPF is tied to law. It's tied to law, so it cannot increase or decrease. It's whatever the law says. So let's calculate, BHCPF will give us X million of households. The VGF, where you have the SIF, the Special Intervention Fund in the NHIA Act, is not tied to any law. If you add the SIF and the BHCPF NHIS together, every year we can agree on a number to say this year we have available money through the BHCPF and the SIF to fund 5 million households, 10 million households. Even if there's a recession, then from service-wide votes, Federal Ministry of Finance is able to match. I think that would be an accountable way to move our discussion so we can begin to say BHCPF NHIS, Special Intervention Fund from the NHIA Act, and whatever comes in from sugar-sweetened beverages. This annually will fund 10 million people. Sir, without looking at this discussion from this perspective, it might be a hard sell. UHC might be a hard sell for us. So I just wanted to close to show that already Nigeria has gone far in identifying poor and vulnerable households. The National Social Registry, which is an aggregation of state social registries, has at the last count almost 50 million Nigerians identified. If we say that there are about 90 million, but we know where the 50 million are. Okay, can we be bold enough to say, let's bring money out to provide health insurance for 10 million of these people? Or 20 million? That's a kind of political commitment that will get us to universal health coverage. I believe it's not just asking for more money now, but we're asking for money to address a problem, to address a goal. So, and basically just what I've explained in terms of the BHCPF and how we can use such identified people through a financing framework. This is just BHCPF, but you can include sugar-sweetened beverage tax, you can include the SIF. Those three tracks of funds can at least make sure that you are translating public financing for universal health coverage into real and granular understanding for our political leaders. So in closing, sir, I think first our advocacy should go beyond sugar-sweetened beverages. Let's begin to push for pro-health taxes as a group. 2, let's have this earmarked for the sector. 3, let's take an output-oriented expenditure framework where at the beginning of a budget season, the principal parties, the Parliament, Ministry of Finance, Ministry of Health /NHIA, agree to say this is the total number of Nigerians we are covering this year, and this is the money for it. So even if there is a downturn, as we've had in the last 2 years when the BHCPF went down, the Ministry of Finance can then use its discretionary powers through the service-wide vote and make that up. So funding care for that 10 million, for that 15 million will remain sacrosanct. I think that's the way I would like us to frame this discussion, and I believe that several of these things will come out in the panel. Thank you very much. I appreciate it.
Thank you so much, Dr. Olumide. I'm really looking forward to the panel sessions where a lot of these terms and recommendations will be discussed in detail. But before we go into that, we would like to break for tea. Tea would last up until 12:15, and if I'm correct, it's just right outside. Or is it at the restaurant? Sorry, I'll just clarify that. Right, it's right outside, downstairs. So please head downstairs for tea and be back here by 12:15 for the very engaging panel sessions that will follow all of the wonderful presentations we've had. Thank you so much, everyone. And to our online audience, we'll be back by 12:15, so please stay online. Don't leave yet. Thanks. Hi, sorry everyone. Tea break is right here, just behind the hall. So please just head over there, get your tea, sit, and do some networking.
I want to use this opportunity on behalf of my classmates or my classmates to thank the Enterprise Development Center as well as Farm Access for giving us the opportunity to go through the healthcare management program. And I want to thank them for actually coming up with this program, its design and its sustenance, because it has had a lot of impact in all our lives, and we believe ultimately in the life of the country as time goes forward.
Along the many modules, it helped me understand more as a manager, and particularly in the era of COVID, change management process is one of the things that has to, be a key part of any business process at this time, particularly in the health sector where, unfortunately there's a lot, well, maybe fortunately I should say, there's a lot of focus and light on healthcare sector, and so change management process has to be one of the key modules that one has to embody in whatever sector you're in and in whatever space. So for me personally, as a medical director, I'm using a lot of the things I've learned in class to be able to change processes in my organization without disrupting function, and at the end of the day, improving service delivery.
Quality healthcare is a luxury that a large portion of Nigeria's population can't afford. This is Mama Dami, a middle-aged single mother with a health emergency on her hands. At the hospital, she learns that because she has no insurance, she may not get the medical attention that she now desperately needs.
Just give her something, at least to stop the pain. Then I'll run around and look for the money, please.
Her cries for help gets her some support, but it's not enough. This is the story of millions of Nigerians who die every year because they cannot afford quality healthcare. But what if we could rewrite this story? At Farm Access Nigeria, our vision is a Nigeria where anyone, regardless of their economic status, has access to affordable and better health care for themselves and their families. So Mama Dami does not have to panic when her child falls ill. All she needs to do is to go to a facility where she can get the best attention. And because she has health insurance, she is certain that her daughter will be attended to almost immediately. Quality healthcare is not a luxury. It is a necessity, and with a token per year, every Nigerian, regardless of their socioeconomic status, can have access to the best healthcare available through health insurance.
I'm Dr. Olaiwola Bello, the medical director of Subal Hospital. But I think the journey with Farm Access Foundation started about 2011 when there was a program called Idea Community Healthcare Program.
Farm Access Foundation introduced a community-based health insurance scheme in Nigeria as a way to test the paradigm of how people purchase healthcare for themselves. And at the time, we started with the Lagos market women and the farming community in Shonga, Kwara State. Sobo was selected as one of the providers on that scheme. And at the time, to be honest, one of our efforts was to make sure that the quality of service within each of the provider hospitals was improved. And so we introduced safe care to all the providers that were going to be providing care in that program. So that's how Subol was introduced to Farm Access.
So what they required of us were basic safe care standards that we needed to put in place, and we were able to put that in place within 6 months of our first encounter with Farm Access. If not for safe care, I'm very sure I wouldn't be where we are today. We won't be where we are today. It's been very interesting and it actually opened also what quality is all about in medical practice.
So Farm Access Foundation, really, our focus is to improve access to quality healthcare services. And we found that over the years that it's not just about improving healthcare financing from the patient side, but it must at the same time simultaneously improve the quality of care from the side of the hospital. As Farm Access, we teamed up with JCI, which is Joint Commission International, the accrediting body for healthcare facilities based out of the United States, as well as USASA, which is the counterpart in South Africa, to come up with a set of standards, especially for resource-restricted countries such as Nigeria, that allows hospitals to improve their quality without, spending way too much money, but just the basic quality improvement as a stepping stone to international accreditation. So basically, it's not a fail or pass process, but rather it's a stepwise improvement to quality. At level 1, there are a set of standards that you need to implement for you to move on to level 2, and so on to level 3, all the way to level 5. So this is a process that we started over 10 years ago to move hospitals onto a better quality improvement and quality assurance program using a safe care methodology. So Subo, again, started its journey with us many years ago and started in at level 1 and has since been improving using the quality improvement plan. And right now it's at level 4. So when you get to level 4, that means that the level of service that you're providing far outweighs quite a number of hospitals within your peers, and you're almost at the point where you can actually go for international accreditation. It's reflected in the quality of the staff you have, the adoption of clinical protocols and adherence to clinical protocols, the use of technology, the right number of medical staffing per patient within your facility, and quite a number of other initiatives.
Safe care has about 13 elements, and all these elements are geared towards providing services that are safe for the people. It's all about safe care delivery. You have elements that have to do with governance. You need to put governance in place, clinical governance. You want to look at your laboratory. Is it well? Do you have facilities for outpatients to make it safe for them? Is your theater safe? Will it be safe for us to give you patients that will take to theater and the patient will come out alive? A whole lot of things. The basic things like, do you have, if the patient requires oxygen, is it going to get the oxygen? Do you have your ambulance? What is your referral system? If you have a patient that is for primary care and it requires secondary care, are you able to provide the secondary care? Of course, we can provide secondary care. If it requires tertiary care, can you provide it? We have to upgrade a lot of our facilities. For instance, the theater, lamp, all we needed to put in, most of these things we never have. But when safe care came into our practice, we realized that we really needed to scale up, and that was how we had to move. And each time we scale up, there's another level to go through, like starting from level 0, and within 2 years we are able to move up to level 4, which is just one more step to the very final step. And you are able to move progressively, and along the line you have to acquire equipment. You are even trying to give us, but of course, because the practice was actually attracting a lot of clientele for us in terms of patients you are coming. So we were able to really do something where we are able, in all honesty, to be able to raise sufficient funds without even recourse to to borrowing, taking loan from facilities. But the practice was really self-sustaining because people appreciated what we were doing, based on the fact that we have put a lot of structures in place that were very attractive to the patients, and so we are getting satisfactory patronage.
With Subol, you would find the management team, and Dr. Bello in particular, is very, very interested in quality. We just had another assessment last week, and each time we perform an assessment in this facility, you always see the genuine interest for quality. Dr. Bello always wants to know what next. I've never seen anybody more happier to receive a quality improvement than I, as a quality manager. It beats me every time. Because after an assessment, the next thing he asks, he doesn't ask for his report. He wants to know, so when am I getting my quality improvement plan? So with Subo, it's interesting because who doesn't like to work with a facility that wants to work with you? And that's Subo for you. Every time they want to know where they are at, where the weaknesses are. Don't praise me. That's Dr. Bello's stance. Don't praise me. Tell me where I am lacking so I can improve. He would rather you tell him where he's lacking than tell him where he's doing well. So with Subo, it's sort of easy, for lack of a better word, because you can tell that they're ready to work and they want to improve on service.
Subo Hospital has really been the trailblazer, if I can call them that. Dr. Bello has really embraced the quality improvement path. And since he started implementing safe care, I mean, he has been the place to go for best practice for other hospitals to understand what is going on and how quality improvement is being implemented. He has seen footfalls within his facility increase. Much of the community around where his facility is in Alwomashaw local government area has, taken Subo Hospital as the place to go to receive care. In fact, because of the increased utilization, the increased quality in improvement, Subo has actually been able to expand its services and has been visited by so many dignitaries who want to see quality improvement in action using safe care methodology, including Her Royal Highness, the Queen of the Netherlands, Queen Maxima, the Director, Peter Sands from Global Fund, among so many other visitors to Subo to see how they are improving quality of care.
My admonition to colleagues is that this is the way to go. It's just safe care standard. Quality care is always associated with it, so they must engage them. And that's my advice. Any forum I meet people, I say, look, this is something that's been very helpful. Nothing special that we are doing except for the fact that we have bought into the safe care standard, and if you go into it, the result will be very, very rewarding.
With Subo, the immediate goal is to move them from a level 4 to a level 5. Just depending on level 4 performance time. So hopefully we can move them to a level 5 this time. And after that, introduce the safety accreditation product so that the whole world, not just Lagos, can see how good they are and how willing they are as a facility to give out the best that we can.
I think with Subo, it goes to show that, when you adopt a quality improvement program or you're within a quality improvement program, that you have a system that allows for quality improvement across board, not just from the skills of your personnel, but from the equipment and the infrastructure within your healthcare facility. So it's really important that most hospitals, if not all, including the government-owned hospitals, enter into a quality improvement program such as Safe Care. Measuring quality using Safe Care methodology provides a really important pathway to make sure that services are continuously improved and quality of the health outcomes is also measured so that there's a benchmark and identifying areas of improvements needed.
So for facilities who haven't joined Safe Care, my question will be, what are you waiting for? Like, everybody is waking up to the quality wagon, and it's about time you joined it. Everybody wants to go to a facility where they feel safe. Everybody wants to go to a facility where they're sure they'll come out better than they went in. Everybody wants to be respected, and everybody wants their privacy upheld. And that's what Safe Care affords as a quality improvement methodology. And apart from some of the things I've mentioned, it also helps you as a facility cut down on wastage, because we help you look at your processes and help you become better, but just helping you quality assure your process so that from the point where a patient walks in to the point where a patient walks out, they can come out saying, oh, this is a good facility. And they can also tell their brothers, their friends, their neighbors, anybody about that facility. So for us, is that every facility offers quality service so that the populace, everyone in Nigeria, can feel comfortable knowing that when they go to a hospital, they're going to come out better than they went in.
The best thing that happened to my practice in the close to over 25 years I've been in practice is having to associate with Pharmacist Foundation, and Pharmacist Foundation taking me to Safe Care standard.
This opportunity on behalf of my classmates or my classmates to thank the Enterprise Development Center as well as Farm Access for giving us the opportunity to go through the healthcare management program. And I want to thank them for actually coming up with this program, its design and its sustenance, because it has had a lot of impact in all our lives, and we believe ultimately in the life of the country as time goes forward.
Many modules, it helped me understand more as a manager, and particularly in the era of COVID, change management process is one of the things that has to be a key part of any business process at this time, particularly in the health sector where unfortunately there's a lot, well, maybe fortunately I should say, there's a lot of focus and light on healthcare sector, and so change management process has to be one of the key modules that one has to embody in whatever sector you're in and in whatever space. So for me personally, as a medical director, I'm using a lot of the things I've learned in class to be able to change processes in my organization without disrupting function, and at the end of the day, improving service delivery.
Quality healthcare is a luxury that a large portion of Nigeria's population can't afford. This is Mama Dami, a middle-aged single mother with a health emergency on her hands. At the hospital, she learns that because she has no insurance, she may not get the medical attention that she now desperately needs.
Just give her something, at least to stop the pain. Then I'll run around and look for the money, please.
Her cries for help gets her some support, but it is not enough. This is the story of millions of Nigerians who die every year because they cannot afford quality health care. But what if we could rewrite this story?
Are you registered with the health insurance program under this hospital?
At Farm Access Nigeria, our vision is a Nigeria where anyone, regardless of their economic status, has access to affordable and better health care for themselves and their families. So Mama Dami does not have to panic when her child falls ill. All she needs to do is to go to a facility where she can get the best attention. And because she has health insurance, she is certain that her daughter will be attended to almost immediately. Quality health care is not a luxury. It is a necessity, and with a token per year, every Nigerian, regardless of their socioeconomic status, can have access to the best healthcare available through health insurance.
Well, I'm Dr. Olaiwola Bello, the Medical Director of Sugar Hospital. But I think the journey with Farm Access Foundation started about 2011 when there was a program called Ajia Community Healthcare Program.
Farm Access Foundation introduced a community-based health insurance scheme in Nigeria as a way to test the paradigm of how people purchase healthcare for themselves. And at the time, we started with the Lagos market women and the farming community in Shonga, Kwara State. Sobo was selected as one of the providers on that scheme. And at the time, to be honest, one of our efforts was to make sure that the quality of service within each of the provider hospitals was improved. And so we introduced safe care to all the providers that were going to be providing care in that program. So that's how Subo was introduced to Farm Access.
So what they required of us were basic safe care standards that we needed to put in place, and we were able to put that in place within 6 months of our first encounter with Farm Access. If not for safe care, I'm very sure I wouldn't be where we are today. We won't be where we are today. It's been very interesting, and it actually opened also what quality is all about in medical practice.
The Farm Access Foundation, really, our focus is to improve access to quality healthcare services. And we found that over the years that it's not just about improving healthcare financing from the patient side, but it must at the same time simultaneously improve the quality of care from the side of the hospital. As Farm Access, we teamed up with JCI, which is Joint Commission International, the accrediting body for healthcare facilities based out of the United States, as well as COSASA, which is the counterpart in South Africa, to come up with a set of standards especially for resource-restricted countries such as Nigeria, that allows hospitals to improve their quality without, spending way too much money, but just the basic quality improvement as a stepping stone to international accreditation. So basically, it's not a fail or pass process, but rather is a stepwise improvement to quality. At level 1, there are a set of standards that you need to, implement for you to move on to level 2, and so on to level 3, all the way to level 5. So this is a process that we started over 10 years ago to move hospitals onto a better quality improvement and quality assurance program using our safe care methodologies. So SUBO again started its journey with us many years ago and started in at level 1 and has since been improving using the quality improvement plan, and right now it's at level 4. So when you get to level 4, that means that the level of service that you're providing far outweighs quite a number of hospitals within your peers, and you're almost at the point where you can actually go for international accreditation. It's reflected in the quality of the staff you have, the adoption of clinical protocols and adherence to clinical protocols, the use of technology, the right number of medical staffing per patient within your facility, and quite a number of other initiatives.
Safe care has about 13 elements, and all these elements are geared towards providing services that are safe for the people. It's all about safe care delivery. You have elements that have to do with governance. You need to put governance in place, clinical governance. You want to look at your laboratory. Is it well? Do you have facilities for outpatients to make it safe for them? Is your theater safe? Will it be safe for us to give you patients that we take to theater and the patient will come out and a whole lot of things. Basic things like, do you have, if the patient requires oxygen, is he going to get the oxygen? Do you have your ambulance? What is your referral system? If you have a patient that is for primary care and it requires secondary care, are you going to provide the secondary care? Of course, you can provide secondary care. If it requires tertiary care, can you provide it? We have to upgrade a lot of facilities. For instance, the theater, lamp, all we needed to put in place. Most of these things we never have, but when safe care came into our practice, we realized that we really needed to scale up, and that was how we had to move. And each time we scale up, there's still another level to go through, like starting from level 0, and within 2 years we are able to move up to level 4, which is just one more step to the very final step. And we are able to move progressively, and along the line, you have to acquire equipment. You are even trying to give us, but of course, because the practice was actually attracting a lot of clientele for us in terms of patients you are coming. So we were able to really do something where we are able, in all honesty, to be able to raise sufficient funds without even recourse to borrowing, taking loans from facilities. But the practice was really self-sustaining because people appreciated what we were doing, based on the fact that we have put a lot of structures in place that were very attractive to the patients, and so we are getting satisfactory patronage.
With SUBO, you would find the management team, and Dr. Bello in particular, is very, very interested in quality. We just had another assessment last week, and each time we perform an assessment in this facility, you always see the genuine interest for quality. Dr. Bello always wants to know what next. I've never seen anybody more happier to receive a quality improvement plan, and even I as a quality manager, it beats me every time. Because after an assessment, the next thing he doesn't ask for his report, he wants to know, so when am I getting my quality improvement plan? So with SUBO, it's interesting because who doesn't like to work with a facility that wants to work with you? And that's SUBO for you. Every time they want to know where they are at, where the weaknesses are. Don't praise me. That's Dr. Bello's stance. Don't praise me. Tell me where I am lacking so I can improve. He would rather you tell him where he's lacking than tell him where he's doing well. So with SUBO, it's sort of easy, for lack of a better word, because you can tell that they're ready to work and they want to improve on service.
So SUBO Hospital has really been a trailblazer if I can call them that. Dr. Bello has really embraced the quality improvement path. And since he started implementing safe care, I mean, he has been the place to go for best practice for other hospitals to understand what is going on and how quality improvement is being implemented. He has seen footfalls within his facility increase. Much of the community around where his facility is in Alonashore local government area has, taken Subo Hospital as the place to go to receive care. In fact, because of the increased utilization, the increased quality in improvement, Subo has actually been able to expand its services and has been visited by so many dignitaries who want to see quality improvement in action using safe care methodology, including Her Royal Highness, the Queen of the Netherlands, Queen Maxima, the Director, Peter Sands from Global Fund, among so many other visitors to Subo to see how they are improving quality of care.
My admonition to colleagues is that this is the way to go. It's just safe care standard. Quality care is always associated with it. So they must engage them. And that's my advice. Any forum I meet people and say, look, this is something that's been very helpful. Nothing special that we are doing except for the fact that we have bought into the safe care standard, and if you go into it, the results will be very, very rewarding.
With Subo, the immediate goal is to move them from a level 4 to a level 5, because they've been on level 4 for the longest time. So hopefully we can move them to a level 5 this time. And after that, introduce the safe care accreditation product so that the whole world, not just Lagos, can see how good they are and how willing they are as a facility to give out the best that they can.
I think with Subo, it goes to show that, when you adopt a quality improvement program or you're within a quality improvement program, that you have a system that allows for quality improvement across board, not just from the skills of your personnel, but from the equipment and the infrastructure within your healthcare facility. So that it's really important that most hospitals, if not all, including the government-owned hospitals, enter into a quality improvement program such as safe care. Measuring quality using safe care methodology provides a really important pathway to make sure that services are continuously improved and quality of the health outcomes is also measured so that there's a benchmark and identifying areas of improvements needed.
So for facility,
Miss Doctor.
Hi, everyone. Good afternoon. So we'll be starting shortly, but while we prepare to start, please, could you just kindly do us a favor and occupy the seats in front, please? Could you move forward, please? There are a lot of empty seats in front. Please oblige us and just move forward. If there's an empty table in front of you, please move to it so that those online can see your pretty and handsome faces. Thank you. Thank you. Thank you for moving forward. Please move forward. Please occupy the seats in front. Please occupy the seats in front. I see some of our in-person participants ignoring me, acting like no one is asking them to move forward. Please move forward, please. Oblige me and move forward and take the seats in front. I don't want to have to point at. I will usher you myself if I have to. Don't make me usher you. I'm a very good usher. I'm very effective. You can't say no to me once I walk up to you. So if you don't want me to walk up to you, please occupy the seats in front. I see people already moving. Thank you. Thank you. Thank you. Okay, did you enjoy your tea? Honestly, even if you don't answer, I'll just assume that everyone enjoyed tea. So now we have come to the panel sessions for today, and I'm sure everyone has been looking forward to it. It's been a very interesting discussion up until now. We've already had some excellent, contributions and insightful takes on how the pro-health taxes can be implemented in Nigeria. We've heard lessons from other countries, from the Philippines, and we've seen from our colleague at Farm Access Ghana how they achieved UHC, or how they're working towards achieving UHC. So, to take us further in this dialogue, I would like to introduce the members of the first panel, who will be discussing implementing the sugar-sweetened beverages tax, the progress, challenges, and opportunities thus far. And before I introduce our esteemed moderator, I'd like to introduce to you those who will be speaking on this panel. First, we have Dr. Zainab Bagudu, who is Her Excellency, thank you for that correction. I'd like to introduce Her Excellency Dr. Zainab Bagudu, who is a pediatric consultant and is a loud voice in the fight against cancer and a child's rights advocate. She's the First Lady of Kebbi State, and she has used that platform to advocate effectively for children's health, and her advocacy for women, children, and the youth in the state and in northern Nigeria cuts across health, education, and skills acquisition. Dr. Zainab Bagudu will be joining us online. Thank you so much for being with us this morning, now afternoon. Secondly, I'd like to introduce the representative of Dr. Ngozi Azodo, who we heard from earlier. She is Dr. Uzoma Owankwo, who is the Assistant Director of the Department of Health, Financing and Equity at the Federal Ministry of Health. She's here representing Dr. Ngozi Azodo, the Director of Health Planning, Research and Statistics at the Federal Ministry of Health. Please put your hands together as I make welcome Dr. Uzoma Owankwo. Apologies, I said she, it's a he. Let's make welcome Dr. Uzoma Owankwo as he takes his seat. Thirdly, I'd like to introduce Dr. Jonathan Eke, who is the General Manager at the National Health Insurance Authority. Please come up here, Dr. Uzoma. You can take any of the seats. Just ignore Yeah. Ignore the names there. So Dr. Jonathan Eke, General Manager at the National Health Insurance Authority. Please put your hands together for him. He is a public health economist with over 15 years of experience in health financing and health systems reforms. He currently serves as the Honorable Commissioner for Health. Oh, apologies. He is the General Manager at the National Health Insurance Authority, and he has a postgraduate certificate in health economics from the University of York in the UK. Next, I'd like to introduce Dr. Oyebanji Filani, who is the Commissioner for Health and Human Services at Ekiti State, and is the chairman of the Health Commissioners Forum. He is a public health economist with over 15 years of experience in health financing and health systems reforms, and he currently serves as the Honorable Commissioner for Health and Human Services at Ekiti State. He'll be joining us online. Thank you so much, Dr. Oyebanji Filani, for joining us. And finally, I would like to introduce Mr. Oluseun Onibinde, who is the founder, CEO of Budgets, and is a Nigerian entrepreneur and open data analyst, popularly known as the co-founder and CEO of Budgets. I'm sure everyone here knows what Budget is, one of our foremost Nigeria civic startups. And he's a fiscal transparency advocate and firm believer in the power of open data. In 2012, he was awarded the Future Awards Prize for Science and Tech Innovation. He's also joining us online. Thank you, Mr. Oluseun Onibinde, for being with us this afternoon. And finally, I'd like to introduce our excellent moderator for this session, Dr. Francis Ukuije, who is a health economist, a medical doctor, public health specialist with over 11 years of progressive government, private sector, and NGO experience. He gained automatic entry into the Federal Ministry of Health in 2007, having earned the prestigious Nigerian President's Honor Award as the best and most outstanding corps member in Nigeria between 2005 and 2006. He'll be moderating this session, and I would yield the mic to him now as he takes over. Thank you so much, sir. Thank you.
Okay, thank you very much. I was actually wondering who gave her the information that she was giving out to the public. I'm not sure that quite a good number of people knew that about me before now, but thank you very much for that introduction. So I would like to stand on the existing protocols and thank my colleagues who are here on this panel, both physically here with me and those who are online. Will it be useful for us to confirm those who are really online so that we know exactly how to go? So everybody is online. So I can see Her Excellency. Thank you very much. So we start. So the discussion since morning is around pro-health taxes and the issues of pro-health taxes in Nigeria. It's not just emerging. So it has been with us for some time. So it's been many years of advocacy and dialogue and provision of evidence to see whether we can resource the health sector better. As we know today, the Nigerian health sector is not doing as good as it's supposed to in terms of how much we spend on health. But really, when you look at it, just like my colleague had mentioned earlier, it's not really about how much that we have for health, even though we need more money for health. But I think what really is important is how we are able to utilize this fund in a manner that represents value for money. And for WHO, we look at value for money from the position of 5 E's, which represents economy, efficiency, effectiveness, equity, and ethics. But for Nigeria, we are very excited about this amount that we have on sugar that has been appropriated on the Finance Act 2021. And the debate is, how do we make the best out of it for the health sector in Nigeria? Now, there are quite a good number of issues that we will bring to the fore. And some of these include, so this sugar tax is here with us. And we know that the implementation has already commenced. So how do we collect this tax? Where actually does it go to? How much of it is going to be dedicated to health? So will it be an earmark, or will it just be some form of prioritization for health? How do we prioritize what is finally dedicated to health? So will it be based on need? And truly, when it is based on need, what will it be? And I know that already there is this conversation about, is it going to be prioritized for non-communicable disease programs, or is it going to go for any other thing? So these are all debates and issues that we need to take a look at. So who implements on behalf of the health sector actually, and how do we determine this? And how does such earmark impact on the general government revenue, general government budget for health? Because we have seen, even in recent past, that even when we have such funding that is appropriated from some of the sources, it has a way of getting away from the general government budget when you compare with the previous. And finally, does the government have the capacity to utilize these resources? And finally, when it is utilized, how do we ensure accountability for this utilization? So it is at this point I want to turn to my colleagues that are the panelists. So Dr. Uzoma is representing the Director of Health Planning Research and Statistics, Dr. Ngozi Azodo. And he is the representative of the Federal Ministry of Health on this panel. Perhaps it will be useful to start with you to begin to look at what you actually see as the real opportunity in this SSB that we are talking about.
Good afternoon, everybody. Is this working? Good afternoon, everybody. Thank you. So, speakers before me since the beginning of the sessions, people who spoke during plenary, had very well set the tone for the conversation. We recognize that raising revenue for health is something that is a very, very important and the first fundamental part of financing health. That is even within the conversations around ability to absorb funds. But we know that Nigeria is not yet spending as much as it should spend on the health of Nigerians. And this healthcare expenditure is not the absolute sole responsibility of the Federal Ministry of Health headquarters. Of course, health spending happens across different levels of government and even across sectors. The National Health Account studies that we have conducted over the years puts per capita spending on health somewhere around 20 USD, not up to what we would desire, somewhere around 80-something plus US dollar per capita. But what opportunities do we have? We're beginning to see a lot of reforms in the healthcare space, and that is thanks to a lot of advocates within the health financing spectrum. We're seeing more intentional and predictable mechanisms. Dr. Ororigbe when he was here, did allude to some of the very bold steps government had taken, and it's not just limited to the executive arm. We've had collaboration, very good collaboration between the legislature and the executive, and of course civil society groups, to begin to see a situation where we can predict what comes to health, and therefore it's possible to now have a basis for planning. The conversations around ability to absorb, for instance, hinges also on even knowing what is coming. So now that it is known what consolidated revenue account would look like, a 1% of it, it is possible for people to now begin to articulate how that potentially is used. So the opportunities that exist, as I see it, the conversation, I like the fact that the conversation was broadened a little bit beyond sugar-sweetened beverages, because if you even do the maths, you're missing out. Olumide's presentation was spot on. You're missing out a lot of leeway. Nigeria has a population of 200 plus million people consuming both alcohol, sugar-sweetened beverages in very high volumes. So the opportunity to actually harness all of this revenue puts us in a place where we can, without really looking at just what comes out of government allocations and budgets, we can really expand the fiscal space. And when that happens, Dr. Gafar is in the room, and the civil society group has also been doing a lot of work on the accountability framework. And that also means that we have systems we're discussing in place to also ensure that when we're looking for more revenues, we don't also have situations where funds are being returned. So I think it's an unfolding conversation. The opportunities are very clear, and you speak to NCDs. NCDs are spot on the reason why we're even taxing, and we can't exclude them from the discussions. And I think that in everybody sharing their views and opinions, these are curated and become issues that the legislators use as policy-making tools. Those will be my first comments.
Okay. Yeah, thank you very much, Dr. Uzoma. I would like to go to Dr. Eke. Dr. Uzoma had just mentioned that the government expenditure on health is low, and we have it on record from the NHA that per capita expenditure on health, at least as at 2019, that is the validated data, is about $14 per capita. Again, I would turn it over to you. So do you actually see much opportunities on the SSB?
Yeah. Thank you very much. Thank you very much, listeners. I think that the SSB provides opportunities for us to at least deepen the financing of the health system. But first of all, like a lot of other speakers have said before, we are talking about how do we earmark this funding to the health sector when we have what we have talked about, capacity, poor capacity utilization of the funding that have been given before. So that is one. We need to look at, first of all, how do we deal with this poor capacity utilization? Because there is no basis for us to go and ask for more money from the finance when the little ones that are given to us, we cannot spend it. So for this SSB, though the rate at which we are collecting it may not really get us the impact, because from a little computation, it tells you that we are just doing less than 5%. And I think what is the recommended is about 20%, because the taxation is almost has a unit elasticity, so that for you to get an impact, you need to go up to 20% for you to get a 20% reduction. If we want to use it to, first of all, achieve the objective of reducing the morbidity that LCDs give, and two, where we are for what we are talking about here, which is raising revenue, that has to be done. And two, for universal health coverage, I think, like some other countries, for example, Philippines, I think Thailand are equally using it to finance access to services, especially for the vulnerable persons. Recently, like my Director General said in his opening remark, we have a new law that has made health insurance mandatory in Nigeria, and within that law, we have a provision for what we call the Vulnerable Groups Fund. And part of sources of funding for that Vulnerable Groups Fund is what we call Special Intervention Fund and Health Insurance Levy. I think that, first of all, it's not just about earmarking. Like my friend from Ghana said, one, you earmark, and you ring-fence and prioritize where you send the money to areas where you can achieve maximum efficiency, maximum equity, and effectiveness of the fund. And I think that whatever that they generate, which at this level might be marginal, we think that the health insurance should take it. I think this should be where I start the discussion. Thank you.
Okay, thank you very much, Dr. Eke. I'll go online, and I will go to Her Excellency, Dr. Bagudu. There is one thing about making a law, and the other one is about implementing it. We all here have seen over the years what happened, especially even with the Basic Healthcare Provision Fund that took about 4 years from the time the National Health Act was enacted and the beginning of the implementation of the Basic Healthcare Provision Fund, starting from its appropriation on the budget. So I would like to ask Your Excellency, from the position of Nigeria having 3 tiers, the federal, the state, and the local government. So what do you think will be some of the policy barriers towards implementation, successful implementation of the SSB tax? Over to you, Your Excellency.
Well, good afternoon, everyone. It's a pleasure to be here. Sorry, I think I have you on 2 devices. Is there an echo?
No, we can hear you.
Okay, I thought
we can hear you.
I definitely have you on the second device. I need to turn it off. It's echoing my end. It's still echoing. I was just trying to anyway. Well, as you rightly said, in our healthcare system, we operate not centralized. We don't have separate laws that the state is supposed to enact, and then the federal government doesn't. However, the state government does have some leverage on how it carries out its own laws and how it implements certain taxes. Obviously, if we had a pool of funds coming in from this type of tax, this thing is echoing. If we had a pool of funds coming in from such a tax as this, which is something that we've all been advocating for and successfully finally got it into the budget last year, and it's now happening, it would go into a common pool and be divided appropriately, appropriated across all the states. It shouldn't really make a difference how each state spends its own or each local government, but as long as there is a directive from the Federal Ministry of Health on this, on how it should be spent. If the ministry guides and the council, health council guides as well, there will be some adherence to that at the state and local government levels. But I think that the more important question that we need to ask and things that we need to address beyond the spending agency is how to ensure that we get the sugar tax funding to the health sector. Just by virtue of the name, the reason it was created, why we need it, and so on and so forth, all of which have been beautifully enumerated in this meeting. we cannot fold our arms and watch while it's diverted to another sector. Either there are 101 competing needs for every local government, for every state government, for every federal government. But if there is a specific need and that sector has specifically taxed itself, found a way to tax that sector so that we can have more funding into it, then there's no justification for moving it to building roads. We must ensure that it is put towards the health of our people. And then the other issue along that same line, which you mentioned now, is about the other funds that we've seen, similar funds like the Basic Healthcare Provision Fund, and of more importance to me, the Cancer Health Fund. We design these very beautifully. We even advocate for them. We lobby everybody that needs to be lobbied until the laws are passed and the taxation starts. But there is no clear-cut directive on how it's going to be spent. And so in the beginning of the Basic Healthcare Fund, we're still in the beginning of the Cancer Health Fund, there's a lot of agitation and misunderstanding because the stakeholders that are involved in the spending process have not been carried along or have not had adequate inputs into the way in which the law is being delivered. And eventually they're tasked with the responsibility of spending this money. So there's a whole confusion, the planners have done it one way and the implementing agency thinks this is the way they should do it. And the agitators like ourselves, we get upset and we need to find new ways of making it work. Somehow we might eventually get there, but the key is to start it right. Now I'm glad to see this kind of meeting where we have everybody on the table, the ministry, the DG budget, everybody that needs to be here is here today, the DG of the NSIA and everyone else. So that is it's a good start, but we must stop talking and let's have the clear plans and how to do it. We keep on talking and talking about how to do this. I believe this is our 10th meeting or so, and we need to have a sit-down, proper meeting with those that matter in the room. The Minister of Finance, she pulled our assistants into agitating for this taxation, the budget sector, the NHIA, everybody. And we lobby the legislatures. There's this misconception that we don't lobby in Nigeria or in African countries, but we do and we can. Maybe people don't know what goes on behind the scenes, but we can lobby. So the same way that we've been lobbied to agitate for these taxes and met with the legislators and all the public hearings and everything, and it's now finally happened. It's time for us to go back and see those that matter and ask them, how are we going to spend this money at each level of government so that our people can be the ultimate beneficiaries? Okay, I hope I didn't sway too much from your question.
No, this is very, very useful.
I think I did.
Yes, it's very useful, Your Excellency. You have actually raised a number of key issues that we need to take into consideration. And truly, you mentioned that we need to start it right. And I just want to base on that statement about starting it right and then go to Dr. Filani. So in starting it right, we need to also recognize the political economy of Nigeria as a federal entity. So if we need to start it right, just like Her Excellency has advised. So are there some of those political economic considerations you would like to point us to towards the successful implementation of this task, Dr. Filani?
First and foremost, protocols observed, and I would like to appreciate the organizers, members of the panel as well who are here. I think it's important before we even go into what the political economy looks like to understand the journey as to where we started the DG budget. I'd alluded to that. And in late 2016, I recall very clearly that the former Minister of Health, Professor Adewale, had commissioned a study to explore innovative options for financing health in Nigeria. So it's really exciting and pleasing to see that the analytical work, which really began in his office at the time, was supported by a number of partners, including WHO, the World Bank, and others, has helped move the policy implementation along significantly to where we are. But beyond that also is then what do we know as at today? And we've heard a number of speakers give insight as to where we are. The DG budget spoke, a few others have also talked about it. We have an act that is in place, and that means that there's a legal backing and framework for us to be able to move forward. There are implementation challenges, obviously, driven largely by the political economy. And some of that include the electoral cycle, which was pointed at earlier on, and also which we need to take into consideration as we go into another election year next year, or electoral cycle next year, right? There's the conversation around the industry lobbyists and the implication of that on being able to move forward with collection, right? And then of course there's a conversation around the cost of collection, right? If based on the numbers quoted earlier, if same taxes, specifically the sweet beverages, as 12 billion, there's a cost to collecting that. So the actual amount that comes in eventually is not really 12 billion, but less than that. And so for us in the sector, we need to, the way we engage, right, has to be slightly different. Our conversation should, given that it is not finalized with respect to where the money should go, our conversations on how the generated revenues should be utilized should cover, conversation around, does it go into the general government revenue, or should it be earmarked into the health sector, right? And so what should we do? I think it's important that we stay involved. And this is the political economy, right? We stay involved with the Ministry of Finance through the entire process. The conversation around, 10 naira per liter, for instance, and the average size of the sugary drinks and the implication of that to amount charged. The Ministry of Health should be very involved. And when I mean Ministry of Health, I'm talking at the federal, the agencies, and even at the state, right? We all should be very involved in that conversation and not wait until all of that has been done, the money has come in, and then we begin to request, right? So that's one. The second is within this period when this conversation is going on, it's important that we demonstrate the absorptive capacity to utilize the resources that we have. And the federal government has a number of levers and instruments to do that, and I'll touch on that shortly. And also frame the narrative within the health sector in a positive light in terms of what we've done, how well we've achieved, and what we need to move forward with. The third, of course, then is, we need to also present a compelling case, right, for these additional resources and then clarify where it should go. I'm less inclined, and I think Joe Kotsain sort of like alluded to that as well, to us focusing on earmarking the resources, particularly for health, because again, there are so many other taxes that could come in place. So if these resources go into the general government revenue, if we are there in the conversations very early enough, what we could be focusing on is how to ensure that as the big pie gets increased, that the health sector percentage also increases, and that's critical. Closely then related to this is once it comes to health, the conversation should be where exactly in health should it go to? And from a state perspective, I think we already have, an instrument, right, or a product, if you want to use that word, that allows us to do it. The federal government really should be focusing, if once this money resources come into the health sector, should be focusing on funding an explicit package, right, of health services for all Nigerians. And the mechanism is there. The Basic Healthcare Provision Fund offers us this opportunity. It has helped to resolve some of the, PFM challenges that's typically associated with interfiscal transfers. And so by passing these funds, whenever they come into the health sector, right, through the BHCPF, you can guarantee that they're sent electronically to service delivery points. And that ensures that we're able to get more bang for our buck, because then you're purchasing a set of services. So this is the way I see it. And just to recap, from political economic conversation from the health sector, one is that we should, from the very beginning, be involved in the conversations and not wait till when the money comes or the money is generated. Secondly, is that as a sector, we must continue to demonstrate that absorptive capacity and, frame the narrative around how, the resources that we have are being utilized. The third, of course, is when it eventually comes, we already have a mechanism at the federal level, right, to utilize these resources. And so it's to put it through the BHCPF to be able to purchase an explicit but guaranteed set of services. Thank you very much.
Okay, thank you very much, Dr. Filani. I know that Sheu is with us, the CEO of Budget. So, Sheu, I'll go to you right away. Because these issues have been outlined, so real political economy issues, so potential policy and political barriers towards the implementation. Perhaps you have an insight into what needs to be done. Again, coming from your position, from the private sector and CSO position, and engaging the government and the public so far. So what would be your advice on what steps that need to be taken by the government to ensure that this instrument that has been put in place is successfully implemented and on time?
Thank you so much. It's a pleasure, and thank you so much, Farm Access, for inviting me, and thanks everyone listening. And I feel that a lot of the issues have been well structured. The issue around the SSBs are critical, considering the mortalities that we get from NCDs, and all the other elements in there. And I feel that what we have done is critical, but maybe it's not punitive enough. And I think someone has alluded to that. That's where we have to start from. We want to put taxes on sugar drinks and all that, but if we're not doing within what the WHO recommends, the recommendation is there for a reason. If we're not able to eat the target of what the WHO recommends, then definitely we have not been able to incentivize behavior around the whole purchase of sugary drinks. And that, I think, is where the conversation should start first. This is a global movement that's been proven to show results in Mexico or across the country. So it's critical that we sit in that effectively. The second thing about it's also the size of fund that's been raised from this. Still not enough. I mean, we're a country of 200 million people. We can talk about that size of funds, 12 billion, and says that's what we would think would transform things heavily. The health sector itself, if we're going to reach the 15% budget declaration at all levels, we'll be talking about expenditure I'm talking about federal, state, local government. We're talking about supposing I put an extra 1 trillion naira in the ground. So those are the kind of things that we have to ask ourselves. What would go way far? What would move fast? And if we're not even able to hit the target to create that incentive by getting the tax to be higher than what it is, it's important. And I also like what Dr. Filani said around marking and then being able to warehouse in some of these funds. If these taxes get into that bottomless pit, they call the consolidated revenue fund, it's going to be difficult for you to be able to say tangibly, this is what makes it different. If we're going to get a bit of results from the National Health Act, based on the 1% that we have from there, it's because there are specific directives of how the resources should be managed. So we also have to come into that conversation about being creating an ego high and being, watching around the accountability of funds. And the accountability means the funds are specifically targeted to certain issues. If we're going to be using it to improve tertiary education, tertiary health systems, if that's the way, since we know that NCDs are the things that we're trying to fight against here, so be it. If it's going to be primary healthcare system that we use to build equity and access, so be it. We need to make sure that accountability can only be enhanced when it is narrowed down to the purpose of the use of funds. So I think I will sit into all of this, but I think to wrap up back again, I will start from the fact that the incentive is not strong enough, with the taxes still very, very low. The amounts that we've generated is still relatively low, no matter how much we try to look at this. And most importantly is that we need to get accountability levels up. And the only way we can do that more effective is if we can narrow the fund for some certain level of, we are asking them for some specific purposes. Thank you.
Okay, thank you very much, Sheu. Just before you go, I'll just like to ask you, so can you tell us just 3 things you think the health sector can do? Because as we speak, this money has not been earmarked for health. So can you advise on 3 things the health sector can do to ensure that this is earmarked for the health sector?
I mean, this is about policy making. If we are going to earmark funds from the Consolidated Revenue Fund, definitely it has to be backed by legislation. So maybe this is because that's something we did with National Health Act. Elements like the NDDC or like which are able to get some certain percentage of revenue, or even the NEDC, that's National Northeast Development Commission, they were backed by her. So if anybody is going to take anything from the Consolidated Revenue and warehouse, it can't just be a policy statement. It has to be backed by the law, and that's the only way to institutionalize it. I think it's time to bring National Assembly and legislators much more stronger on this, and also get a bit of interest from the executive effectively. And I think the second thing we'll also now do is who would manage the use of the funds. I don't want us to be another round of agency, but it might mean that the the Ministry of Health would also be much more involved in this. Let's not lie that these funds will be collected at the federal level, and so definitely it will still be distributed at the state level. I think also an important part that if the states know that they can get an extra buck from the SSB tax, then definitely they'll put more scrutiny and maybe in terms of compliance. So we also have to integrate the state framework into it. This can't just be something that is just being managed, just being expended solely at the federal level effectively. And I think the third thing you also want to build is bring non-state actor into it. Accountability of when it comes to taxes, accountability is critical because taxes are a key element of the social contract. So accountability will be a key element in this as much as possible. Thank you.
Okay, thank you very much. So just assuming that this money is now earmarked for health, again, this can happen. We take the example of the Basic Healthcare Provision Fund. It looks like we were not ready as at the time the money came. So are there things we need to begin to put in place to ensure that we begin to even see where to put this money into? So Dr. Eke, is it possible for you to give us a little idea of where we can utilize this fund and truly how to begin to get ready?
Thank you very much. I think within, let me speak from the point of view of where I work, the Mansan, because we are equally asking for this fund. And we are equally implementing the Basic Healthcare Provision Fund. I do not think that the problem will be about strategies of utilizing, because we already have it and we're already doing that. We are implementing the BACPF, and like the law I quoted, talking about the Vulnerable Groups Fund, it's in fact the Basic Healthcare Provision Fund is a component of that Vulnerable Groups Fund. So if that fund comes to the National Health Insurance Authority as a big pool, it's still the big pool, but the implementation is done by the state health insurance agencies and state health insurance schemes. So I don't think there is any new thing that we need to define. We already have an accountability framework that is in the guideline of the BACPF. In fact, within the authority, we have even developed an in-house accountability framework for the basic healthcare. And from the discussion we're having already, we think that if we get the Vulnerable Groups Fund, we are going to implement it using the BACPF approach. So what I'm saying is this: if we get this tax, and we decide to, okay, first of all, the finance agrees to earmark it through health, and then we equally inside and agree that we are going to ring fence it for health insurance. We are ready to start it anytime. So I do not think that there's anything more that the system is, because we're already implementing the BACPF. I think I have to leave that. Thank you.
Okay, yeah, thank you very much. That's very useful. So the Basic Healthcare Provision, the Basic Healthcare Provision Fund, the Vulnerable People's Fund, and indeed they already have systems that have been put in place, including accountability frameworks. But let me go to Her Excellency. So Her Excellency has really been an advocate for a number of initiatives within the country, including non-communicable diseases. But I just want to ask you, Your Excellency. So again, what do you think will be the best use of these resources when it comes to health? What are your thoughts about some of the various priorities that can be placed on this funding that may be coming to health for its better and appropriate use, Your Excellency?
Well, at this point, I understand what people like the director of budget go through when they say they need to prioritize. For me, as a healthcare professional with a little understanding of how government works and a passionate cancer advocate, it's a very easy question in a way, and also very difficult. There are so many needs, but for me, I would put it in non-communicable diseases. The direct impact of these sugars are on the non-communicable diseases. We think we're not even up to the amounts that we're supposed to be getting. It's not up to the percentage yet. It's like our cancer health fund is just under $1 billion. And I always say I can spend this $1 billion in a week on my cancer patients. Legitimately, it will not solve the problem. It will not even start to scratch the surface of 260 million Nigerians. If I decide to just use it for simple awareness and screening, it cannot go around the entire country. So I would put it in non-communicable diseases. I'd zone it down to cancers. I'd zone it down to creating better education and screening for our people in the common cancers, which are breast, prostate, and cervical. And so we have male and females being covered there. And I'd further zone it down to prevention of things like vaccinations for our girls. Nigeria is the largest country in Africa, and we're still not giving our girls HPV vaccine, where we hope every day we're about to start, but the commonly cited reason is lack of availability, and then funding. So if we have these pool of funds, let us go and advocate to the Governors Forum, let us go and advocate to the Minister of Finance that we should put it towards specific needs. I'm sure the diabetes people will tell you that they need it as well. And it's true, we can make a list and then we'll find out how much money we have and allocate it to. But the most important thing is that it must go to the health sector. It must. We're not going to accept it if it doesn't.
Okay, thank you very much, Your Excellency. We are not going to accept it if it doesn't come to the health sector. I agree entirely with you. But I think we are going to come to the audience shortly for some questions to the panelists. But it looks like I would ask Dr. Filani one more question, because he is Commissioner for Health in Ekiti State. And we are looking here at how this funding can impact on the whole of the health system in Nigeria, both at the federal and at the state levels. So with the kind of significant strides that you have made in the health sector in Ekiti State, Dr. Filani, if this funding comes, what do you think it can do at the state level?
Thanks. So there's a lot that it can do, but I think, again, to the point that I made earlier, the first thing is to be setting that we can, when we engage with the Ministries of Finance and the Ministry of Budget, that we're able to commit to using those funds for specific things. And it's when you do that, then you can speak to outcomes, or you can measure the results that you would have. And so for us in the health sector, let's recall that states already fund significantly primary health care, provide significant resources for secondary care as well. And in some instances, depending on the states, there's also a tertiary care funding. right? The complement to this, of course, is making sure that we're able to purchase additional services or purchase an explicit but guaranteed package of services for people, particularly those who have limited traction or are unable to spend or have the disposable income to be able to fund this. And I hear the point very well made by Our Excellency, Dr. Bagudu, with respect to funding NCD. I think these are not mutually exclusive. I think within the benefit package that I've just highlighted or that I've spoken about, that NCDs can be incorporated, and it's not just even screening, right? But even management and treatment of hypertension and diabetes at the primary of care level to start with, right? I think that's something that could be incorporated. Of course, we need to think through the implications of this on the package size, but also on the cost of the package. But it really should be at the state level. It really should be a conversation about how many more lives are we getting, are we funding, who are covered, for a defined package of care. And that's where I think it should go. Thank you.
Okay, thank you very much, Dr. Filani. So I will come to you to ask a few questions. So please get them ready in a few minutes. But Dr. Uzoma, before I go to the audience, so you represent the Federal Ministry of Health. And indeed, the Federal Ministry of Health has the responsibility of coordinating and superintending over all of this. Some mistakes have been made in the past in managing some situations like this in the country. Of course, the most recent is that of the Basic Healthcare Provision Fund. And when my friend from Ghana, Maxwell, was also speaking, he was saying we should actually be wary so that we don't jump into some of those mistakes and that they have made in their country and some other countries. So what do you think from the Federal Ministry of Health perspective that can really be done differently this time?
Thank you very much, Dr. Francis, and I acknowledge all the contributions of my fellow panelists. There are a couple of things that I don't want us to lose sight of. So currently now, during plenary, if you would recall, previous speakers had alluded to the fact that there is a lot on the table, on the plate, and if we're not careful, we're going to, from the perspective of raising revenue, one of the very important functions of financing health. If we're not careful, we're going to narrow the conversations. We're talking about earmarking a very small fraction of what is possible, right?
Yeah.
Earlier in the day when the DG budget spoke, he said that a lot of sectors beyond health, and he used the example of if you don't have access to road infrastructure, access to the facilities, you wouldn't even be able to get there. But to that, there was some very interesting work done over 20 years ago. The WHO Commission on Macroeconomics and Health by Professor Jeffrey Sachs. And it established that you invest in health, development follows, basically. So that point is already very, very well made. And of course, that takes us very interestingly to not also forgetting why we're even talking about the taxes. The main reason is for the health of the people, and that means to deter bad behavior, as I would like to put it. It means that the taxations and the proportions and the rates that are being placed, whether they are specific or proportionate, that it should be enough to really deter consumption. And because what we have seen from the cigarette taxes that were imposed is that it did not quite increase as was anticipated. So the conversations around earmarking what we have now, I would like for stakeholders not to lose the eyes on the targets, on that broader picture of really mobilizing all of the revenues that are possible. Because from the health sector perspective, we see the fiscal space and we know that we do require a lot of funding, not necessarily spent, because a lot of these things we do at the Federal Ministry of Health level are actually funds. For instance, the NHIS mandatory insurance makes provisions for providing care for over 80 million vulnerable persons. And we have to be able to think about how to structure, work out a structured way of financing that, because it's a law, we're mandated to do that. But in terms of this conversation we're having here, it would be good that we think about mobilizing everything that's on the table, because we'll have a lot against us. The industry is really out there. So I think those are the sorts of things that are probably possible. And just to flag something else, we're in an election year. Many of us have our inclinations, and we have access to some of the major actors. This is actually the time to get people to make commitments that we can hold them accountable for. It's really the time. The experiences from Ghana are well noted, and so we have a lot of mechanisms now and platforms. There's a Basic Health Provision Fund, there is the Vulnerable People's Fund, there's NHIS, the NPHCDA also is a recipient of funds. The the NCDC also is a recipient of funds. All of these are all things that contribute to healthcare delivery. What is it that we're looking at in terms of doing differently? Well, he spoke about the accountability framework within the NHIS. That's Dr. Chris is on the line, I think, the secretary of the BHCPF. And one thing that everybody's very big on is that, so we're not the ones who are implementing the Federal Ministry of Health. Responsibilities are devolved. And the NHIS, the National Health Insurance Authority, we're also looking at an authority that will begin to be a regulator, okay, and then allow implementation to be at another level, so that they too can begin to hold people, account. So those are some of those things that the system itself is also growing and evolving, so that we avoid some of the pitfalls that we had experienced in the past. But just to say that we should all congratulate ourselves. We're making very, very big strides if you have an idea of the big picture, and but we should not narrow the conversation to earmarking the little that we have. There is a bigger pot that we should still stay focused on. Thank you.
Okay, thank you very much, Dr. Zoma. So let me come to you. There are a number of hands up. So I saw that you were the first, the lady in front, and then the other lady just behind her. And then perhaps I can take one more. If you show your hand, I will count. Okay, so no more hand. So let's take the two very quickly. Yes, go ahead. Introduce yourself and ask your question or make your comment. We'll restrict it to just one comment or one question per person. Thank you very much.
Hello. Good afternoon, everybody. Is this mic working at all? Good afternoon, everybody.
Yes.
My name is Iweze Rose. I'm an M&E consultant. The very question I want to ask is the Minister of Health representative. It looks as if you're shifting your responsibility to the state. And I align myself with what I just said. Most of these things supposed to be, they are looking up to you for the directives. So you cannot say they should do whatever they want to do. Okay, that's that. I mean, I have a couple of, messages. Now, coming to the NHIS or NHIA, I thought that if we have monies that are being returned, or probably the money accruing from this SSB, don't you think, are we not pushing towards getting a free, health insurance for everybody, rather than, the vulnerable, they also have some money to pay. Like, is it not 15,000? So are we also not talking about having a free, health insurance for all?
That's okay. That's okay. So I'll go to the next lady. Please pass the microphone over. Thank you very much. So please, we'll restrict it to either one comment or one question per person. Please go. Yes.
Thank you. Good afternoon, everyone. Good to be here. My name is Abimbola Adesomi. I'm a Senior Special Assistant on Nutrition to the President, and I represent the Nutrition Council here. And I think I will first of all congratulate Farm Access, World Bank, and Health Watch for this forum, and go straight to what I have to say. Thank you, panelists, for sharing your insights on the health financing through SSB tax. One of the things that we are particular about is the two risk factors for NCDs, which is obesity and overweight. They are malnutrition. And one of the things that bothers us is that these two risk factors also have potential impact on stunting in the country. We're not advocating for nutrition out of the health sector. It is within the health sector, because sugar-sweetened beverages are actually consumed
there are a behavioral problem in the population. What we're looking at and what I want to ask is how we see these funds earmarked or being earmarked towards a life cycle approach for preventive care rather than curative. So Her Excellency, the First Lady, talked about NCDs, and then she drilled down to say prevention. So what we're looking at is prevention mostly for NCDs is to look at the behavioral approach. How can we influence behaviors? And how can we, through the health financing, look at the three trusts of the universal health care that we're all proposing? First, financing, mitigating financing risk through the National Health Insurance Program. The second has to do with quality healthcare services, which also maybe perhaps health can help me with through the Basic Healthcare Provision Fund. Do we have nutrition services that could help influence population health through behavioral change? And the third has to do with attainment of the SDGs, which the states could help me, subnational level could help me answer. Thank you very much.
All right, thank you very much. Yes, I saw one other hand up. Yes, we'll just take that. And then perhaps because we're running short of time. Okay, yes. Yes, thank you very much. Dr. Gadak, please go on.
Okay, thank you very much. My name is Dr. Agada Amade. I work with NHIA. So I just want to talk about the importance of creating effective demand for health.
Yep.
So we have mentioned a lot of things, and this is appreciating all the panelists and the anchor. How do we get our people to start assessing care in the hospitals? So if you want to do your wellness and all that, how do you have access to it? If you think about the guy in the village, in the most remote part of Nigeria, how do you have access? How does it trickle down to that guy, that pregnant woman, that obese person? How do you provide access to health? And I think that when we are prioritizing, we should be looking at how creating effective demand for whatever we have.
Yeah.
So at a point, can we begin to also talk with NHIA and say, and the state social health insurance, and say, how can you work on your benefit package to begin to cover some of these areas? But I think if we really want to get anything from this earmark tax, we should begin to talk of creation of demand, enabling our people, empowering them to be able to go to hospital and access care. And one of the critical ways you can use, and it's not because I work for NHIA, but it's definitely one of the key areas that you can do your investment. And you know what that does for you? It also enables the health system, strengthening of the health system, for them to also begin to develop the supply side, to be empowered to really invest in that area directly from the hospitals. Thank you very much.
All right, thank you very much. And then to my other colleague at the back, and that will be for the question and answer sessions. I think we would leave it at this for now. Yes, please, go ahead.
Thank you, sir, and good afternoon, everybody. I just want to comment with regards to the last
yes, I'll come.
speaker's comment with regards to NHIS being allowed to handle the business of regulating health insurance in the country. I will still refer you to the NHIA Act that was enacted sometimes 2 months ago, where the functions of the organization were specifically specified, being a promoter, a regulator, as well as integrator of health insurance business in the country. If you go elsewhere and you see where health insurance is being practiced across the globe, so many national health insurance authorities are involved in the business of even carrying out the functions or the activity of health insurance, not only regulating, but also partaking in the business itself. I will also refer you to the integration policy document of health insurance under our roof, where the metrics of coverage was clearly stated in order to avoid duplication, disintegration, and confusion within the health insurance ecosystem. The Health Insurance Authority have its own metrics of coverage, while the state social health insurance authorities also have their own metrics of coverage. In the same NHIA Act 2022, it was clearly specified that the NHIA should provide the basic minimum service package, which will be approved by the Honorable Minister. And it also clearly stated that a scheme should be established under the NHIA to provide health insurance services or business or coverage as the case may be. So the issue of a health insurance authority being a regulator, well, it has been a recurring decimal, so many people raising up that issue, but this has been buried by the Act. It now has a legal backing clearly stating that this is what is expected of it, and this is what the people or the generality of the people should expect from it. Thank you.
All right, thank you very much, Dr. Basha. So I'll come back to the panel and we will close. So what I would ask is, so there is an issue raised around health insurance. I would like Dr. Eke to handle that. And then I think some other things that were raised were just comments. And perhaps if Dr. Eke would take that issue around insurance, he would also make his final remarks within just 1 minute. And then I'll give 1 minute each to each panelist to make their final pitch and remarks before we close the session. So Dr. Eke.
Yeah, thank you very much. Thank you very much. Well, before I answer that question, I want to thank Dr. Agada for raising up what he said. It's about benefit package. What does your benefit package contain? I have listened to everybody who talk about preventive care. The benefit package you are providing also contains preventive care. It contains promotive care, and the benefit package that we are given covers the NCDs that we are talking about. We have cancer control. In fact, within the NHS system, it covers cancer, you take care of diabetes, you take care of hypertension, and a lot of all these NCDs that arise because of some of these challenges we are talking about. Now, the lady asked whether what we are talking about, we're not pushing for free health insurance. I don't think there is anything like any free thing anywhere in the world. Somebody's got to pay. What the law has just established is a mandatory health insurance. And within the frame of the mandatory health insurance, what we will do is those that can afford to pay, they are going to be mandated through entry points to make sure that they make their contribution. For those that cannot afford to pay, the government has created, that's why I was talking about the Vulnerable Groups Fund. That's what the government has created to finance, to be able to take care of those people. And in fact, when the president signed this law, he said that the government is going to cover 83 million Nigerians who are vulnerable. And how do we generate this fund within the context of the macro fiscal constraints facing Nigeria and the world? So we begin to look at other means of generating it without putting pressure on government. And I think that this source of financing and other ones, like when the Senate Committee Chairman on Health was talking, he mentioned about the telecom tax. I think when the law was being framed, there was a misunderstanding. People thought that the telecom tax was a tax that's going to be levied on the telecoms company, but that's not correct. It's supposed to be a levy that as you make a call, you won't even feel it. And either 1 kobo or 2 kobo is going to finance some of these things. But the good thing we've gathered today is that we are beginning to realize the mistake, and that's the starting point, so that we can go back and see how we can generate the kind of resources we need to attain universal health coverage. To cover about 83 million Nigerians, vulnerable persons we require monies not in billions, but money that run into trillions to be able. And I do not think that what the Basic Healthcare Provision Fund provides, like some people are talking, all the funds that we have received for the Basic Healthcare Provision Fund in the last 2 years that we have been, it's only for 1.3 million people. So, and the government say we are going to cover 83 million persons. So you can see that we still need other sources of funding to ensure that we get this. So thank you very much.
All right, thanks a lot, Dr. Eke. So, Dr. Uzoma, what is your last speech? 1 minute.
Thank you. And I want to thank the Senior Special Assistant to Mr. President on Nutrition for the comment she made. And that relates to the interrogating the NHIA's benefit package. Now, if you recall, one of the things that we had flagged in the course of this conversation is that the rate of increase of these taxes, beyond just raising revenue, has to be sufficient to deter the behavior, because the ultimate outcome is to ensure that Nigerians are not burdened with diseases that further impoverish them, in the sense that they lose their health, lose productivity time, and they spend subsistence, their funding for subsistence on their health. So that's really very, very important. And the other thing that would happen with this fund is that, you see, if you look at the mechanism, the metrics of health expenditure, Dr. Francis will recall that out-of-pocket expenditure is really very high. So if we're able to mobilize funds from the general pool and provide some basic minimum package of health services, which should, because now we're discussing pro-health taxes, should adequately provide for some of those non-communicable diseases, okay, in any platform in which we want to spend, but then that would put a dent on the amount of money people are paying for healthcare out of pocket, because that's what we're trying to do in the health space, is to be consistent in reducing the amount of money people are spending and provide what we call financial risk protection for Nigerians. So thank you very much for the opportunity to speak.
Thank you very much. So I go to Her Excellency. Please, in 1 minute, please, can you give us your final word? So, your
Okay, yes.
Excellency.
Yes, now I can. Can you hear me now?
Yes, please go ahead.
Yes. So as taxation for the benefits of health, or indeed any other sector of development, is a reality that we have to face, and it's one that will only serve to help us more. We do not have issues with policies in Nigeria as a country. What we have issues with is the implementation of these policies and the accountability. There's been a lot of robust discussion in this webinar, and indeed others, about how we can implement this particular sugar tax better. The important thing is for us to pass this message on to those that are responsible for implementing it, so that we can have the outcomes that we desire. The sugar tax is here. We hope that it will increase further, and we strongly, finally urge that it is directed towards interventions in the health sector.
Okay, thank you very much. Excellency, Dr. Filani, 1 minute.
You can go.
Okay, so perhaps we go to Shehu if Dr. Filani is not readily available.
Okay, thanks so much. I'm grateful, and there's been great comments, great conversation from the audience. I think two things are critical for me. Skill. We need to do much to get skills. Start of a great thing, but the size of what we have right now is still not enough in terms of the size of, compared to the challenges that we have in the healthcare sector. We are going to have purpose vehicles to fund healthcare. We are going to have things like SSB. What we are achieving right now is still relatively small. Second thing is accountability. I already mentioned that accountability will come strongly when we are able to earmark and clearly say this is where we'll propose the fund. But maybe it's still kept within the CRF. It's really challenging for you to define what sorts out of and what delivers what. I think this is a great conversation and a good opportunity to leverage health sector focused finances. Thank you very much for inviting me.
Okay, thank you very much. Dr. Filani, are you here now?
Yes, I am. Thanks and apologies for that delay. So first, again, I think this has been a very insightful discussion, and it's timely. I would have three major things to talk about. We need to realize and recognize that this conversation we're having really should be about is around how the government increases the fiscal space. And that's the first conversation, whether it's through the sugar ones, whether it's through communication tax or any of the other additional taxes, right? And as players within the health sector, we must be involved in the conversation around how those resources should then be utilized. General government revenue versus, dedicated or earmarked for health, right? Once it comes into the health sector, we also have to be ready to provide, what I call demonstrable capacity and capabilities that we know how to use the fund and where we're going to utilize it. And that's twofold. One, between now and when the conversation is sorted out on where the funding will go, is to show that we have that absorptive capacity. The second is to ensure that the existing mechanism, which is the basic healthcare provision fund, and I continue to go back to that because when I wrap my head around vulnerable group versus VHPF, I think it's one and the same. It's just a semantic around, what you want to call it, right? Is that you already have a proven mechanism to transfer resources from the federal government to states, but not just anywhere in the state, it's directly to service delivery points using electronic means of transfer. And that allows you to minimize wastages, allows you to plug leakages, and ensures that the funds reach where they should be and purchase a set of services. So thank you once again for the opportunity to be on this panel, and I've enjoyed very thoroughly some of the very insightful discussions and discourse that have come out, and I look forward to the rest of the session. Over.
So I think we're going to stop this at this point. So let me just quickly recap. I want to thank my colleagues who have really done justice to this very panel, which is looking at how best we can implement the SSB task for the greater benefits for Nigeria. We started by Her Excellency really giving us that, will I call it an instruction or an advice to ensure that we start it right. And in starting it right, we need to ensure very clear and consistent stakeholder engagement. And this will help us not to fall into the pitfalls of the old in days and years and the mistakes that have been made before, even in other countries. But we also are asked to make a very compelling case for the health sector. And how do we do this? Because there are other taxes that are actually competing with this. So we need to demonstrate that the health sector does not only have the capacity to utilize this, but we utilize it in a way that is value for money. And indeed, we need to make a business case to show that there is good returns on investment, but also ensuring that we utilize systems that are already existing without having to create new ones, while ensuring that we prioritize what we can buy with these resources, and finally put accountability framework in place to ensure that we track progress. But we are not going to end without mentioning that we know that this money that we're talking about is, it can really be huge, but it truly might not be enough. So actually, how much do we need? The most important thing is that we need to start making incremental steps towards ensuring that we increase the fiscal space for health. At this point, I want to thank my colleagues, and I know that there is the next session that will be dealing on some of the other innovative ways of raising money for health that probably will not be this SSB. Thank you very much for your attention.
Thank you very much, Dr. Francis, for moderating that session. We need a photo shoot for the session, and our photographers are already standing by. Maxwell, please, you called upon. Emeka, please can you join? Thank you. Dr. Gafar, please can you join for the photo shoot? Thank you very much. Just a few seconds, Dr. Gafar is joining the photo shoot. Are we gender balanced? Dr. Winter, please, could you step up to join? And Mrs. Sonia, please, for gender balance. Thank you very much. I'm sure for people here present and those online, you would agree that it has been a very, very worthwhile and fantastic session today. This dialogue, this policy dialogue on healthcare financing in Nigeria. Again, Dr. Francis, thank you for the fantastic session, panel one. We quickly move to the next panel discussion. The next panel discussion promises to be very, very interesting also. I know that Dr. Eke was speaking when he mentioned 3 things to be done to earmark funds for health. That there is need for us to ensure that policies are backed up by law. We need to ensure that managing funds efficiently are implemented, and of course, the accountability bar needs to be raised. The second panel discussion is going to focus on innovative mechanisms for healthcare financing. And we will be addressing earmarking taxes for health at both the national and subnational levels in Nigeria. We have a panel of discussants on this particular discussion, which promises to also be very, very insightful. So permit me to introduce each of our panelists to the podium for those that are with us here, and also to introduce those that will be joining us virtually. We have Dr. Adebobola Bashorun, who is the Deputy Director of Public Health of the Federal Ministry of Health, that will be ably representing Dr. Morenike Alex Oko, who is the Director of Public Health, Federal Ministry of Health. Dr. Adebobola Bashorun is an insightful, dynamic, and performance-driven medical doctor with over 15 years experience in the field of medicine at clinical, public health, and policy-making levels. A well-trained medical and field epidemiologist, a graduate of the Nigerian Field Epidemiology Program, and a public health specialist with a master's degree in public health, master's degree in public administration, and a PhD holder in public health. Permit me to call on the podium Dr. Adebobola Bashorun. Please come forward. A round of applause for Dr. Adebobola Bashorun. Dr. Adebobola Bashorun, I'm sure he will join us in a bit. The second panelist I'll be introducing today, he will be joining us virtually, and that is Dr. Chukwu Nkata. He is the founding partner, Health Systems Consult Limited. Dr. Chukwu Nkata is a medical doctor and health economist with over 18 years experience in health system strengthening, public health programs design and implementation. He's a leading strategic purchasing specialist and is passionate about universal health coverage. Dr. Nkata is already joining us online. A very good afternoon to you, sir. You are welcome to this program today. Going on, I want to introduce Dr. Adeyeye Arigbabuwo, who is the president of the Healthcare Providers Association of Nigeria. Dr. Adeyeye Arigbabuwo, please come on the podium. A round of applause for him. We also have in our midst today, who will be joining on the second panel, Dr. Anne Adaogo. She will be representing Dr. Tinola Akimbolagbe, who is the CEO, Private Sector Health Alliance of Nigeria. Dr. Anne is a public health expert with the Private Health Sector Alliance of Nigeria. She is currently the head of policy and programs and has vast program management experience. Dr. Anne is currently a medical doctor who holds a master's degree from the University of Western Cape, a member of the Global Project Management Institute, project management certification from APMG, Buckinghamshire, and risk manager. A round of applause for her as she's welcome to the podium. Dr. Anne, please come up. A round of applause for her, please, as she walks up to the podium. You are welcome, ma. The next panelist who is also amongst us today, this afternoon, is Mr. Runsi Chidebe. He's the Executive Director, Project Pink Blue, Health and Psychological Trust Center. Mr. Runsi is a patient advocate, psychologist, and global health consultant. He's the Executive Director of Project Pink Blue, a cancer not-for-profit focused on cancer control in Nigeria. He's engaged in supporting people battling with cancer, fundraising for indigent patients, cancer awareness, and established Nigeria's first patient navigation. He's an external academic board member of the Birmingham and Lewisham African and Caribbean Health Inequalities Review of the United Kingdom. You are welcome. Please come on stage, Mr. Runsi. A round of applause for him. Finally, on this panel, we have Dr. Mohammed Al-Kali, the President, Diabetes Association of Nigeria, who also is joining us online. He's also the Chief Medical Director of the Abubakar Tafawa Balewa University Teaching Hospital. A round of applause for him as he joins us online. And of course, to moderate this great panel, this very, very promising and interesting panel, is a very, very special person to me. He's like a senior brother, also a mentor, Dr. Gafar Alawode. Dr. Gafar Alawode is an experienced public health practitioner, and he has managed several donor-funded development projects at senior level in Nigeria and other developing countries, including Liberia and Uganda. He was a country manager for Liverpool Associates in Tropical Health, state team lead for DFID funded partnership for Transforming Health Systems, Part 2, chief of party for the USAID funded health financing and governance project, and also country director for Health Policy Plus. Dr. Gafar designed and worked with other stakeholders to introduce the universal health coverage related innovations, including legislative network for universal health coverage and Universal Health Coverage 2023 Forum, which is an initiative geared towards putting UHC on the political front burner ahead of the 2023 general elections. He was appointed a member of the core group for health financing resilience community of practice by the World Bank. He is presently a managing partner at DGI Consult Limited, and he heads prevention epidemics project, being managed by Lisdell as the project director. He obtained his master's degree in tropical medicine in the United Kingdom after acquiring first degree in medicine and surgery from the best university in Nigeria, University of Ilorin. Yes, better by far. He is a member of the United Kingdom Faculty of Public Health of the Royal College of Physicians. Please permit me to welcome Dr. Gafar and a round of applause for him. Thank you very much.
Good afternoon, everyone, and welcome to this panel conversation, where we want to continue conversation in terms of how do we mobilize additional resources for health. This time around, we are looking at innovative financing beyond SSB. We are looking at what are the additional earmark funds at the national and state level. How do we mobilize resources from the private sector and trust fund, including other innovative approaches as well. And we know that financing could be more political than technical. We look at how do we take advantage of the policy reset window that comes with the election. As we approach the 2023 election, we'll look at that as well. The first panel started and dwelled heavily around public financing. I would like to start with the private financing this time around. And we are very lucky to have a private sector health alliance here, doing a very, very great job looking at how to mobilize private resources. Dr. Han, we have not been able to fully tap into the private sector resources to finance health in Nigeria. But the experience of COVID tells us that it is possible. Because during COVID, we were able to mobilize a lot of resources from the private sector. Then the question to you is that your organization, what are you doing? What models should we use in a sustained manner to mobilize private sector resources to bridge resource gap in the health sector?
Many thanks, Dr. Gafar, and it's a pleasure to be here. Good afternoon to everyone. So in terms of tapping into resources from the private sector, one currency that's very important is for us to continually build the trust that is currently eroded between the public sector and the private sector. We seem to have a lot around the issue of trust, accountability, ensuring value for money, reducing wastages and plugging leaks in the system. For private sector, because we're very much driven by value for money, ensuring that every dollar or naira contributed to the health sector counts and makes a difference. It's important that if the public sector is to tap into business with the private sector, they need to demonstrate a high level of accountability. There has to be a demonstration of proof of concept that whatever we're going to put these funds into is targeted at producing results, is targeted at improving health outcomes for the poorest and the most vulnerable Nigerians, is targeted at equity and ensuring that across the divide, we speak to the emerging health trends. That you can see that our pattern of health care or needs across the health sector is evolving. So if we must tap into resources in the private sector, we have to be looking at some of these issues. It's also important that we bring evidence to the table in terms of resource mobilization, because for private sector, most of our investments is driven by evidence real time. So we need to see where the needs are, that these needs are clearly demonstrated, there is proof of concept, and that funding gap is backed by evidence as driven by data.
Okay, thank you very much. But are there specific models what Private Sector Health Alliance is doing now? We know all those best practices are very, very important. in terms of a specific model of how you are collecting money from the Dangotes of this world and Jimovian and all those, what model are you using, and what can state and at the national level learn from that to bridge resource gap?
So some of the projects that we have carried out, our biggest project currently is the Adopt a Healthcare Facility, primary healthcare facility, which is adopting one primary healthcare in each of the 774 local government area in Nigeria. How are we financing this model, where we're mobilizing resources from the private sector and supporting government in the public sector to ensure health access is improved? What we simply have done is to demonstrate a need. Private Sector Health Alliance is a bridge builder between the organized private sector and the public sector. So what we have done is to demonstrate proof of concept that there is a need in the public sector at the primary healthcare centers, because we believe that primary healthcare is the foundation of improving healthcare and achieving universal health coverage in Nigeria. So we have gone back to the private sector, we have done a baseline analysis, we have a tangible product that we have shown to the private sector, and we have shown them the reason why they need to invest. So we have adopters, philanthropists, well-meaning Nigerians, high net worth individuals, HNIs as we call them, who have demonstrated interest in adopting this health facility. So they're partnering with government through Private Sector Health Alliance to be able to provide healthcare to Nigerians who need it in some of the most difficult terrains. That's one model that we have used to bring private sector contribution to public sector. Something else that we have done is also to get the private sector to see through small projects that we have done, the Nigerian Health Innovative Markets, where we have done small pilot projects in communities. We have demonstrated that these work, and now we have philanthropists, we have high net worth individuals, we have companies who are willing to now put money to improving healthcare, outcomes. We are also working with banks to provide financing at low cost to private sector individuals or private sector organizations, and this has helped, to provide financing to improve the quality of commodities, healthcare commodities, that come into the market, so that we're not importing a lot, we're also reducing imports, and then we're reducing costs. Maybe lastly that I would speak about is we have also been able to work with the private sector so that some of these investments in the health sector can be reported and they get tax holidays from it, because for the private sector there has to be a reason why they are interested in investing in the public sector. So what we have provided for them is a platform that allows them to report expenses on health in Nigeria, and they are able to enjoy tax holidays from their expenditure on health before tax.
Great, thank you very much, Dr. Hada. That is very, very helpful. So I'll go to Dr. Nkata now. As we discuss additional possible earmark funding for health, I think it's very, very important for us to learn from the existing ring-fenced funds. At the national level, we have the Basic Care Provision Fund. At the state level, we have the Equity Fund. So Dr. Nkata, as one of the stakeholders that is very, very involved in the design and supporting at the national and state level in the implementation of this earmark fund, what lessons have we learned that should guide future earmarking of funds for health? Dr. Nkata.
Thank you very much, Dr. Ganiu, and thanks a lot to all the organizers for inviting me to this very important dialogue. So I think I'm just drawing from the conversations we had earlier in the day. I remember the DG budget mentioning and I think also the experience from Ghana, talking about earmarking is one thing, right? But then when we earmark, and this is what we've been experiencing in Nigeria, when we say we're earmarking 1% of the consolidated revenue fund for the BHCPF, Now, that money first, does it eventually get released? Because it's not being earmarked in policy or by law, but does it eventually get released? Now, even more importantly is what is released, does it get utilized? You know, does it just stay in the account to having very sad situations like returning 6 billion naira when we're actually complaining that we don't have enough? So the big lesson with earmarking is not a silver bullet that solves your problems. The funds that are being earmarked, have you thought about how those funds will be collected and transferred? So if they're earmarked for health, how does it go from finance to health? Does it actually get released to health? When it gets to health, how does it get utilized? Have the systems and capabilities been built to utilize that money? Because it deflates the system and all the stakeholders when after all the advocacy and all the noise, we get the money and it doesn't get utilized. So have we thought about what it takes to utilize this money effectively? Money is easy to spend until you're looking at spending it effectively and efficient. Then you find that a lot of times, you start having delays. So as we think about earmarking, we should look at the fact that just taking BHCPF as a clear example, how much releases have we had since 2014 to date? And of what has been released, what has been the percentage drawdown? So the big lesson with earmarking is not a term that solves all the problems. Even if you go all the way to ring fencing and all that, have we deliberately developed the capabilities to implement? Now, just quickly, before I move away from this, on the SSB tax that have been implemented, we had a roundtable discussion with our colleagues from the private sector in NESG, the Nigerian Economic Summit Group. Some of those who are traditionally opposed to any additional taxes, be it for health, education, or anything. And one of the things they raised is, while we're focusing on SSB, there is a tobacco excise duty that probably generates more money than the SSB. And I do remember that earlier, a few months back, the Minister for Finance actually announced that implementation of the increase in the ad valorem tobacco excise from 20 to 30% will commence 1st of June, which is last month, and run for 2 years all the way to 2024 before it's reviewed. How much money are we looking at? How does that play into this conversation around additional money to be earmarked? So just like the previous speakers have mentioned, so we don't lose focus of the bigger picture because we're looking at earmarking SSB. But like I mentioned, just to recap, earmarking is not a silver bullet. When the money is earmarked, have we actually built the capabilities, the frameworks to utilize the money, account for it, demonstrate results, and demonstrate that earmarking, getting additional resources for health and earmarking and reinforcing them actually makes any difference. Thank you. I'll pause here for now. Thanks.
Okay, thank you very much, Dr. Nkata. Before I go to Dr. Arigbabu, you mentioned a lot of important points, but I want you to emphasize something. You talk about demonstrating a result with the funds. That's a big issue that we've been discussing. In your own opinion, when you get SSB, when you get even from the basic care provision fund, how do you think the health sector should be demonstrating results that this money is making the difference?
Okay, so yes, thank you, Dr. Gafar, for that follow-on question. So I think we've done a lot of groundwork. We've laid a lot of the foundation that at this point, building on it and demonstrating results should be easy. The first thing, which I think for me is one of the biggest victories of the BHCPF, is the fact that we have defined a package of care, right? Because it's difficult to measure when you don't have a defined package or a defined product or service that your money is going into. That's one. The second one is just looking at delivering services to people. Any additional resource to the sector should not start going back to funding inputs getting ticked off by administrative charges and all that, but to actually looking at how many more Nigerians, right, can this deliver that minimum package to? And Dr. Lumide of the World Bank, the Commissioner, Dr. Banji, alluded to that. You know, how many more people is so, even in a state that has a state health insurance scheme and has 100,000 people covered by the health insurance scheme receiving a package of care, when they get BATPF, how many additional lives is BATPF bringing in? If you give them money from SSB, you sum up state health insurance, BATPF, how many more lives will SSB bring in? So that we can actually tell that we're adding up. Otherwise, what you're going to have is the funds become fungible. Money comes in from SSB or from tobacco, state withdraws some of its original budget or the federal. So you stay at the same point, but then you just keep throwing more money in. You know, so the easiest way really to track this is to look at outcomes, not to be measuring inputs. How many more buildings have you put up? How many more vehicles and ambulances did you buy? How many more people did you recruit? But actually to look at how many more Nigerians are receiving care. Thank you very much.
Okay, great. Thank you very much, Dr. Nkata. Very, very helpful. So, Dr. Haribabu, available statistics suggest that more Nigerians access healthcare from the private provider than the public provider. So, from the private provider perspective, how do you think available earmark funding could be better utilized? What do you think the policymakers should do differently?
Thank you very much. Statistics available shows that between 60 to 70% of the health care earnings and patronage provided by the private sector. Incidentally, this is the sector that is representing the eye of the supply side. In which case, assuming governments have gotten enough healthcare facilities that is public driven, fantastically driven, perhaps the private sector may be less needed, just as is happening in Rwanda and few other countries. However, this is also a sector or a group that I would say is experiencing competition rather than collaboration. And there's a difference between the two. If the private sector, I would say, is helping to work out this adequacy on the supply side, what they need actually is collaboration. Issue of energy is not there. It's epileptic. There are other social infrastructures that this supply side, the private sector, ordinarily will need to be able to add quality to the care to be assessed by the enrollees, for example, or the end users. However, while we are thinking of innovative options to make sure we bring in funds, I've always looked at it, what my Ghanaian friend described as a melting point. I call it the sausage roll or a common pot, or what you call, usually when you go to bukateria to eat or restaurant, you say, give me assorted. So when these things are put in a pot, it's a common pot already. So it doesn't now really matter who contributes to the pot. Everybody bring plates to just take your dish. And whatever you get, you kill the elephant, people come into court. And the hunter who has gone to kill the elephant will begin to wonder whether that was his purpose of going. So I think there must also be audit of the tax collection. You see, for you to appropriate to say, okay, how best do we think it to be done? There are sharp practices, and you will not believe it, both from local government to state and to federal. I was at the taxi park somewhere, a particular airport, I don't want to mention him. The taxi man that carried me gave me something that looked to me like inflated amount. And he said, Oga, 1,000 of this amount to go to the wife of social minister. I wouldn't want to mention. And I said, how? Said that is their own tax that they do. Then their boss who was there was like, that is it, Oga, it's 8,000 will carry you from this airport to that spot. It would not have been up to that if not for so and so thing. And I think we talk about that song, corporate governance. We have to fight, first of all, issue of corruption before we start thinking of distribution and sharp practices. If, for example, what I need to pay as my tax is 500 naira, and if I can do away with you directly with only 200 naira, you tell me to pay 300 naira.
So we have an agreement from the base. Then even what is going to call me is not audited. So having said that, I think if for any reason we look at giving grants or loans that are given at single digit interest rate, for example. So, and we, in fact, we pump it into the private facilities or private health sector. Let me just put it that way. I think the end users who are going to pick up the bills, for example, since we still say 70% or more is still out of pocket payment, they will feel relieved. Just like this sugar beverages tax we're talking about, whatever you push in or you want to cut out from the producer or manufacturer, they will pass the bill, the extra bill to the consumer at the end of the day. Ditto with whatever is happening to us at the health sector. So what we need to do really for the consumers or for the end users to enjoy maximally from the supply side of the facilities, for example, is one, we have thought of it. Can we begin to think of, even the 5,000 naira that were being given to some 40 million Nigerians per month, which they call whether social support, whatever it is, which is a good one. Can we also think of cutting like 250 naira or 500 naira from that particular 5,000, for example, and push it as part of health reserve? I did that and I got some billions of naira, because if you are going to do that to 40 million people per month, for example, multiply that one in a year, you see what to go. They also looked at it at the aviation level. The other time they moved from 25,000 naira ticket to 50,000 minimum, for example. Even did not fall. That is 100% increment. If we do just 1,000 naira on domestic flight alone, and I looked at the domestic flight in the country, and I did it, and I came with several billions of naira, we also got results. And apart from that, what about the toll gate that we're planning to do?
So Dr. Arigbabu, let me interject here. A lot of people have done some of those calculations many years back.
Yes.
You know, the telecom towers and all those.
Yes.
What do you think is the barrier?
Thank you. The barrier mainly, first of all, there will be the reluctance of the payers. Reluctance of the payers to even pay this tax we're talking about, because there are more the correlation. What you collect from social services you are providing. So people begin to challenge. After all, in the UK, we know what's happening in some other countries. If you are earning about 20,000 per annum, pound sterling, you can have 10-15% taxation. What's above 100,000 pound sterling for example, in a year, you're going to get between 45 and 50% to pay. People see services, they see what to do for them to do it. So that constraint, that trust, people begin to wonder, what is the trust? What am I getting back from what's been taken from me? I think that's an area for us to look at. And that's, again, something to the side of government.
Okay, thank you very much, Dr. Arigbabu. So before I go to the virtual audience, Dr. Alkali, let me ask Mr. Arunis Chidebe. I think I learned you are very passionate about cancer care financing and cancer advocate. Generally, I'm very sure you'll be glad last year when the Cancer Health Fund came to being, which is aimed at alleviating financial hardship being faced by cancer patients, and alongside Our Excellency that did a great job as well. So from your own experience, how is it working? What are the issues? What are the challenges? What can we learn and what should we do differently?
Okay, thank you very much. I think the truth is, there are positive lessons that we have actually learned from this, and there are also negative lessons as well. I think the first lesson is that advocacy works, right? We need to speak out, and when you speak out, the tendency that something will happen is there. And there is also this other feedback around it, that the government is listening, that it shows that the government is really interested in the people, and more importantly, the indigent ones. But the problem right now is, which I think that's why this question is so important, so that we can really look at Cancer Health Fund
and see where the mistakes are and ensure we don't make the same mistake in SSB. One of the main challenges with the Cancer Health Fund was that when we actually advocated for this, we did not to some extent clearly state where the money should be and how it should be, how best it should. The problem is the Federal Ministry of Health thinks that the money is for Federal Ministry of Health. The money, the CHF, which is over 1 billion naira, is not Federal Ministry of Health money. It's the money of cancer patient, indigent cancer patient, and should never be used for the purchase of vehicles, project vehicles. This is what we see. So that is number one, ownership of this fund. Number two, what is the framework? As till today, we don't know who have received these funds. We don't know even the steering committees. So there is a need for those clarity. The one other challenge again is that we have people who are working in healthcare leaders who are serving their principles instead of serving the people. So this is where we always get it wrong. And finally, the main huge challenge that we're having with the CHF today is the engagement of the patient. You cannot take care of me better than how I can take care of myself. There is no massive engagement of cancer patients. And when the patients are actually involved, they can guide and direct properly. And finally, it is so painful when I said most of the healthcare leaders trying to serve their principle instead of serving the people. We heard in December that the Federal Ministry of Health was waiting for President Muhammadu Buhari to come and launch the over 1 billion fund before this fund is disbursed to the people. How can we really think? Where is our conscience? Cancer patients are dying every single day, and we are waiting for a whole Mr. President to come and launch the fund for 2 years before these funds are disbursed. So these are the core issues. This fund should never in any way actually be handled by Federal Ministry of Health. Federal Ministry of Health at the moment, with the National Cancer Control Program, is actually 11 people managing the life of over 100,000 people who are battling with cancer. This fund's actually supposed to be with the National Health Insurance Authority so that we can hold, Professor Sambo was here a few minutes ago, we can hold him accountable. The minister is really dragging, malaria is dragging him here, HIV is dragging him here, and when you go to, a lot of people are dragging him. But if anything happened to Cancer Fund, we can all protest and go into the front of National Health Insurance Authority. So these are the core issues. And I think that the SSB is a fantastic opportunity. But we have to really learn from what we are seeing from the CHF to ensure that we make a better difference.
Okay, great. Thank you very much. I think you mentioned a lot of a very, very important point passionately. But the last one you mentioned is the one the health financing experts are very, very concerned about. Why should you put the money in the Federal Ministry of Health in terms of, instead of putting it in a purchasing agency that's able to purchase strategically? As a civil society member, what are you doing what type of advocacy are you doing to reverse that? Oh, thank you very much. So, you see, in December, I'll give you a little bit of history. In December 2016, right? 2015, we led an advocacy to the Senate and to the House of Assembly to actually establish what we call the National Agency for Cancer Control, or the National Institute for Cancer Research and Treatment. Senator Honorable Mohamed Usman worked on this when they were in the National Assembly. And President Muhammadu Buhari actually signed the bill to become an act on 20th December 2016. Till date, this institute hasn't really been implemented, neither has it been gazetted. Now imagine if you have that institute. Just the same way if you go to Kenya, you have the National Cancer Institute. If you go to South Africa, you have an institute for cancer. You go to the US, you have the National Cancer Institute. Don't forget, 120,000 people are actually dying of cancer every single year. So what we are doing at this moment, one, is this advocacy to ensure that before this government leaves, it's just 6 months,
that we're able to get this institute in place. That's one. Secondly, we're already pushing advocacy. Just like what Dr. Nkata said, there is a need for review, there is a need for monitoring and evaluation. Because, I mean, the core goal when Healthcare Federation of Nigeria and so many other organizations was pushing this was that, let's get government to put in something for this. Then donor agency can bring in money. Other people, even philanthropists can bring in money. But what we're saying today, trust becomes a very serious issue, because when you don't trust, when the government brings out its own money and it's not used well, you know, who would be willing to bring that?
Okay, thank you very much. Very, very helpful. So let's go to Dr. Alkali. Dr. Alkali, are you still there, sir?
Yes, thank you. I'm with you.
Okay, thank you very much. So I'm very sure the Diabetes Association was very, very excited when this SSB it was addressed by the law. So considering the fact that we are struggling with is it double burden or triple burden of disease now, the unfinished business of preventive, maternal and child death, and we have NCDs as well, which diabetes is one of the prominent one that constitutes the burden of a disease. So I would like to find out from your community, what are you doing to ensure that there's improved funding towards financing diabetic treatment? And are you part of the discussion SSB to ensure that part of the resources, because different groups have been advocating for different things. So are you advocating for that part of the funding should come to diabetes patients as well? Which in that case I may benefit as well.
Thank you very much. Thank you very much for the opportunity. I think I was introduced as the president of the Diabetes Association of Nigeria, as well as the chief medical director of ATBU, TH. I'm still the president of the Diabetes Association of Nigeria, but I finished my tenure as a CMD, so I'm a former CMD, not current. Having said that, I think we in the Diabetes Association of Nigeria, which is a patient-centered organization, although many of us that are involved actually are not diabetic patients, but we have passion to support people living with diabetes. And this is a very welcome development, and we are part of the agitation that led to the movement that led to this law coming into effect. But like what the previous speaker has said, we welcome it as it is a big opportunity to improve the funding in the health sector, and particularly for the care of diabetes. What we will wish is that, honestly, we have to learn a lot from the past. My colleague was just lamenting about the issue, and we know even the National Health Act that was passed, a lot of the money, even though it earmarked, some of the governments were using it to buy ambulances and build primary health care and other things. I think this one, before we go further, we will wish that there should be specific stakeholders meeting, and that should include all people that are involved, not only people in the government, but people in the private sector and partners and the civil society organizations that are involved in such a thing. So that honestly, the fund has to be defined, how it's going to be used and who is going to be responsible for managing the fund. Not actually the implementation, but there has to be people who are not in co-government that are also have a role in supervising the implementation as earmarked. We feel that is a big starting point for that. And we know the sugars can affect many other diseases. Of course, the NCDs now are interconnected: diabetes, cancer, hypertension, and many of them, they have common linkages. And from one, you can lead to another. But we know directly the sugars affect diabetic patients and the impact on diabetes more than the others. So we think the amount that should go should be defined. And when we say defined, it should be specific in the sense that it should be precise, that it should be used to support patient care, it should be used to improve the service delivery, and particularly there should be a form of subsidy that will support the patient care. The revised National Health Act also has opened another window of opportunity for the care of diabetic patients. But there should be a more focused and aggressive means of improving the uptake so that more of our patients, and we feel those NCDs, since they have a lifelong treatment, the the DG of the National Health Insurance Authority had mentioned, which is true, to manage a simple diabetes, you need 300 to 500,000 in a year. And if there are complications, it runs into millions. That means some form of subsidy has to be brought out for the diabetic patient. And we feel proper implementation of that National Health Insurance Scheme, Insurance Act will improve the funding that we are thinking of. And then the expansion of the sugar tax. Yes, we agree the source of the funding is now maybe these canned drinks and other dispense, but we feel they are not the major source of the harm. We are trying to do harm reduction by discouraging their consumption. Then I feel even the domestic and industrial sugars, the tax need to be extended to them so that we are aggressive in reducing the harm and also increases the amount of money that is coming to address the harm that has already been brought about by them. Now, as far as I'm concerned, the government is not doing enough directly from its budget as it is now. What I mean by that is that we are just at 5% instead of the 15% that is expected. And that 15% is not the maximum, it's set the minimum. And 5% is a far cry from the 15 expected 15%. And as far as the NCDs are concerned, we know that there is a United Nations high-level meeting in 2011 and in 2018, where heads of states, including Nigeria, signed a commitment to be more proactive and to commit more funds to the issues of NCDs. So we want to see money coming directly from the budget to address the issues of NCDs. What is happening is that even some of the states that claim to give the 50% allocation to health, they are including the funding that is coming from donors and partners. That is not what the United Nations is talking about. We have to bring out from our actual budget so that whatever is coming from the partners, it will be an addition to the 15% that we are targeting. And that is very important. The private sector, we have seen how important they are. In the COVID epidemic, we can see how they came and boosted the government response. I think the government has to take the issues of NCD, which has been described now as an epidemic. It's a new epidemic. It's spreading all over.
Okay, Dr. Alkali, thank you very much. I think I'll come back to, I'm very sure some members of the audience have one or two questions to ask. I think before I go to the audience, I want to find out, Dr. Han, so we have seen other countries, because experience of other countries shows a trust fund, we know where we create a trust where people pool resources, could work in terms of tackling probably disease-specific issues. We see HIV Trust Fund in Nigeria recently. Do you think that's a promising approach for mobilizing our resources?
I would say yes and no. And why I would say yes is that in terms of health sector financing, yes, trust funds are the way to go. Right now, people are looking at innovative ways of funding the health sector, knowing that government alone cannot do it. And this is not just in Nigeria, this is across several climes, even in the countries that are in the global north. More and more, there are partnerships between government and the private sector to improve health outcomes. So yes, it is a way to go in the future. What Nigeria needs, reiterating the point Dr. Alkali just made, is to ensure that we have a framework in place to operationalize these trust funds. It's not just enough to say this is a good to do. It's important that the how to do is actually done, put before the this is a good to do. Yes, it's good to do. How do we do it? Where do these funds, what are we going to cater for? Are these costs going to go into capital expenditure, or are they going to go into improving the abysmal health statistics that we have? Are real Nigerians going to benefit, from the establishment of trust funds? What modalities also exist to ensure proper accountability? Because it's a trust fund. A trust fund outlives the life of any of the governing bodies of that trust fund. That's one of the core characteristics of a trust fund. A trust fund is not directed or dictated by the government in power. So we have to make sure that we have enabling laws in place, not ambiguous in any way at all, to ensure effective operationalization of any trust fund at all. We saw what happened with the basic healthcare provision funds. Many years after these funds had been earmarked, it was difficult to implement the basic healthcare provision fund because there was this power tussle. Now we're seeing it again with the cancer health funds. So we need to ensure that before we put funds in place, there has to be a clear framework for operationalization. Then we also have to ensure that there's a connection between the subnationals and the nationals. A lot of these policies and nice things happen at the national level, and there's a disconnect between the national and the subnational. Then lastly, we also have to ensure absolute community participation. We hear about cancer funds that have been earmarked. We do not know if the people who are supposed to benefit from these funds are actually aware about the existence of these funds. So how much information do Nigerians have about the existence or the planned existence, for any of this funding to happen? How do we build an agency in the communities to demand better accountability for a trust fund that has been established? These are germane questions that we need to answer before we think of establishing the various trust funds that we're looking at.
Great, thank you very much, Dr. Han. So we'll go to the audience now. Do we have questions for our panelists? And we should not forget our virtual audience as well. I can see two and okay. So let's start with you over there. And please let us check whether our virtual audience want to ask questions as well, or maybe you put in chat box, I guess. Okay.
Okay, good afternoon once again, everybody. My name is Rosie Weze. Like I introduced myself before, my question is, has there been any framework, in order not to make the same mistake, has there been any framework, like an M&E framework or a policy, that is going to help implement this SSB? Or is it just like another fund that will just go and then hang somewhere, and then the beneficiaries will not be able to benefit from it? Has there been any thorough, like a framework? Is there any legal backing to it? Even before it was, it was said last year, has there been any legal backing or policy developed around so that, and we have to have an M&E attached to it, because that is the way to be able to ensure that the people it is intended for, or the end users or the beneficiaries, will be able to benefit from it. Thank you.
Okay, thank you very much. Young man over there, great.
All right, thank you, moderator and discussants. Ladies and gentlemen, my name is Dr. Malau M. Toma. Actually, I am representing the Director of Public Health in the Federal Ministry of Health, but there was a mix-up in the call for the panelists. But be that as it may, I will just make a short comment and I hand over the mic. For information, there is a national policy for the prevention and control of non-communicable disease. And in that policy, it has clear objectives. One of the objectives is to strengthen governance. The second objective is to promote healthy lifestyle. And under that objective 2, the issues of excise taxes are clearly spelled out across all the risk factors that are driving non-communicable disease, one of which is tobacco use and exposure to secondhand smoke. 2, unhealthy diet, under which we have the sweetened sugar beverages and related beverages. Then harmful consumption of alcohol and the recommended taxes are also there. So if you check down, those are clearly stated. Then there is another objective that talks about reorienting and strengthening the healthcare system to also accelerate the access or attainment of the universal health coverage. So I felt this is information that would be good to give. Then, sir, let me also add that in all this, let us not lose focus that before we develop non-communicable disease, are there determinants? Are there risk factors, which could be primary initial risk factors? Are there intermediate risk factors before the full-blown stage of non-communicable disease? In this discussion, are we mindful of even preventing those risk factors from evolving down to the non-communicable disease that we are talking about? These are issues that we also take this dialogue to look at. So in public health intervention to addressing this, the risk factors should be looked and tackled squarely, ranging from tobacco use, alcohol, unhealthy diet. And you could see over the few months now, there has been a lot of discussion around unhealthy diet, in which sweetened sugar beverages is part of it. So I want to advise strongly that when discussing the earmarking component, the mechanism, I'm happy that we are initiating the processes now, even though the rate is far way down from best global practices. It's far way down because it took us a long time to even get what we have now with respect to tobacco control. And for information, tobacco has its own law called the National Tobacco Control Act 2015. And in section 8 of that act clearly stated that there shall be tobacco control fund. So we are moving this conversation forward to defining the mechanism in which such funds can be gathered and distributed accordingly. Then for the sweetened sugar beverages, this is quite good. I'm very happy, even though the rate is very, very low. That's just like 10 kobo per centiliter. 10 kobo per centiliter. That's 10 naira per liter, which is very, very low. And the industry is even subsidizing this for the customers. They did that for tobacco. They subsidize it for the consumers because it's addictive. So long as they keep their customers addicted, the business and the vicious cycle continue. So in summary, let us look towards the public health approach angle to this as we discuss earmarking, because we don't want people to come down with NCDs. And if they come down with it, we should also provide intervention to address, reduce risk, complications, and bring people back to normal life. That is the way I think we should look at this conversation. Thank you.
So thank you very much. I think you are now a co-opted panelist, so you have made your contributions as well. Very, very useful. Do you have any question from any other question? Okay, great. What of our virtual audience? Any question? Okay, that's fine. I think those are very, very wonderful contributions. I think the first one is around the framework for utilization of the SSB. I think it's part of what we have been discussing, that we did a very robust framework for any form of peer marking, trust fund, and everything. I think part of key lessons that we've learned, if we are looking at any financing mechanism, again, we should start with the end in mind in terms of how much, where will the money come from, how much will it generate, who is the target audience, where should it be domiciled, what is the process of raising the accountability fund. I think at the point when we are in advocating for earmarking, we relegate all those conversation and become afterthoughts. When we get the money, then we are asking the next question in terms of how to spend. I think it's part of the key lessons that we've learned in terms of what we do differently. I think we'll be running off. Okay, let's get the questions, please. So while we're still trying to get the online question, I think those are going to be a very germane thing, key lessons that we learned that we should try as much as possible, have a clear picture of what exactly we want, so that because at times, from the lessons learned, when the money is now here, Mark, there will be a lot of political interest, and some of those important things might be very, very difficult. Can you come and read it out? Yeah. So this is a question, I don't know exactly from who, but the question reads, healthcare system in Nigeria is not getting government attention as expected. What can we do at the grassroots level to complement government efforts to reduce mobility and mortality rates? Perhaps that sounds like more of a question to the civil society at the grassroots. I think, and I like this question, you know, not only at the policy level, at the grassroots level, what can we do to ensure that even the money that is going to the community, we're able to get the best out of it? What should we be doing? Civil society, yeah. Not only cancer this time.
Okay. Okay, thank you very much. I think there's a lot we can really do, and I think there's a lot that is already going on. But what is really missing is the greater extent of really educating the people really understanding that this public health center over there belongs to you. It is your public health center, and anything that happens there, you should know, you should contribute to it. And this is my own recommendation. I think it's high time we begin to sort of really get like steering committees or board members for different PHCs in different local governments, so that this PHC can begin, people can begin to own it and see it as their own, and not just see it as government. You know the same way we have in different schools, you have PTA, right? And the PTA means from time to time to know what is needed in school, especially in private schools. We need something like that. We need, imagine the emir of this particular community or the Igwe of this particular community being also on the steering committee or being a board chair of a PHC. You will see how people can begin to really own this. That's one. Other things we also need to do is to begin to create more awareness in the rural communities, that people can begin to see that health is such an important thing. I mean, I'm not trying to say that a lot of people in the community don't really value their health, but because of poverty and a whole number of other issues, people just want to survive first before even talking about going to any hospital.
Okay, thank you very much. Our time is fast spent. I'll be running off this our panel discussion. So I'll give the panelists one minute. From Inkata, let's take care of our virtual panelists as well. So if any of us on this panel has the opportunity to engage the presidential candidate of major political parties, apology for saying major political parties, any of the major political parties, and you have 3 minutes to make a request in terms of what should be in the manifesto for health. So let's start from Dr. Nkata. What will be your priority if you have the opportunity to, as part of putting health on the political front burner, and what will you do to ensure that it's actually on the political front burner? Dr. Nkata, are you there?
Yes, I am. So the question I would ask them will be primarily in their tenure, within the first 4 years, on a year-on-year basis. How many more Nigerians will they aim every year to provide coverage for healthcare through the health insurance? Because we all agree that to start counting how many people receive care, not how many vehicles are bought to our buildings. So if our current coverage is 10%, how many more Nigerians will they put on before they leave? So that we can count that before the next election and decide whether we vote for them or not.
Great, thank you very much. Counting the number to be sure that specific number, because we have 83 million that are not accessing care now. So, Dr. Alikali, what would you like to ask the president to be?
Thank you very much. I will ask him that health is a very important priority, and he should aim at getting results, not just statements, as far as health is concerned, which means there should be measurable targets where both the quality and the access to healthcare should be improved. And there should be some form of encouragement of funding from other stakeholders, and the funding implementation, the resources should be managed in such a transparent manner that various stakeholders will have a say or will have an input in the management of the resources. Thank you.
Okay, thank you, Dr. Han. How do we put all these policy trust on the political front burner when you engage the political class?
I think this is okay. So one of the first things I would like to say to whichever aspirant it is that we need to have policies, we need to be able to operationalize our policies in a sustainable manner. We also need to ensure that we have workable accountability mechanisms in place as we operationalize our policies. We also need to remember that health cannot be managed alone. It sits amongst all the other social determinants of health, and therefore Nigerians must be at the center of whatever plan the government is making in terms of service delivery and service uptake.
Great, thank you very much, Dr. Aribabu.
On my side, I would like to raise 3 issues for such a candidate. One is the fact that I will ask if there's a conflict of interest between his own convinced agenda and that of the manifesto of his party. Which one will he give priority? Number 2, I will let him know also that health should be prioritized above every other thing in a multi-sectoral competition. And finally, I would love to ask such a candidate that if he had a minister appointed and that minister is returning money back, would that not look like poor performance of budget? And if there is poor performance of budget, how would that drive the country? How would that minister come next time to ask for more funds and we want to release when the one I gave you didn't know what to do with it? Thank you.
Okay, thank you very much. Clear performance framework. Okay.
Okay, thank you very much. I think the first thing I would say is, dear Mr. Incoming President, the health care of Nigerians is currently not really in the hands of Nigerians. It's actually really in the hands of donor agencies. How can we really move that back to the hands of Nigerians? Then secondly, what I would say is, dear Mr. Incoming President, please, can we stop seeing healthcare investment as healthcare expenditure or spending? It is actually an investment. When we have government that begin to see money put into healthcare as an investment, the returns will always be there. And finally, we need more tax incentive. Imagine the philanthropy that we saw during COVID. Over 30 billion naira raised by 181 companies in 2020 in less than 6 months. How can we appreciate these people? We need to increase philanthropy of Nigerians, like gift aid that we have in the UK, that could even encourage personal income taxes to really want to donate to non-profits, to donate to PHCs in a way that we can really grow, indigenous forms and different innovative ways of fundraising. And I think this can only be done by, if you, Mr. Incoming President, that I'm talking to you now as a viable person to lead Nigeria to a better health. Thank you.
Great, thank you very much. And I would like to thank our panelists for this wonderful contribution. I think a number of important points came out of this conversation. I think if you ask me, the number one thing that take away is that why agitating or advocating for any any form of a new financing mechanism, whether here marking trust fund and everything, I think we should do our homework properly, carefully, and try as much as possible to have information and some clarity in terms of how this thing will be implemented, how much are we going to raise from it, who are the intended beneficiaries, how do we reach them, where would the money be domiciled, what are the likely political interests that are likely to hinder this. I think that's very, very important. Number two that I'm getting from this conversation, we need to raise the accountability bar. I've listened to the DG of the budget office. I've been listening to him for the past 3 years on the issue of SSB. The message has been the same. They are not very, very clear about whether the health sector will spend the money efficiently. And the same position is corroborated by the chair Senate Committee on Health. How do you explain the situation where you are returning money and you are asking for more money as well? Basic Care Provision Fund is there for us as an experiment. So we have to, this conversation need to include how do we raise accountability for financing as much as we are asking for more money. Then again, we should see the conversation as not only technical, it is political as well. And how do we ensure that the political class, because in many cases the technical people talk to themselves, and the political class is not even aware of this kind of conversation at times. And that's why deliberately we are looking at how do we up our game in terms of making it political as well. And again, how do we try as much as possible to build trust and confidence between the health sector actors and the central budget agency as well. You can see the body language of the DG budget office in terms of, I think we have not sounded convincing enough. So we have to do more work to try as much as possible to generate the data, to produce the evidence, use the Basic Care Provision Fund. Let's demonstrate this is the result we are getting, and we are not wasteful. And the health sector is not a black box where you just put this and don't know what is happening as well. So on this note, I would like to thank our panelists very well. Both panelists are joined virtually, and our in-house panelists as well. We really appreciate, and we appreciate the audience for the question, for the attention as well. So on this note, by the power conferred on me, I would like to disband the panel, and the panel is hereby disbanded. Thank you very much. Should we take a group picture?
I promised the audience that this panel discussion was going to be very, very interesting. It was on innovative mechanism for financing health. And they are going to have a group photograph now. Dr. Winter, please, can you kindly join the group picture? While we are preparing for the photo shoot, we have a few of our important stakeholders that have been with us since morning, and they are still online. I would like to appreciate and recognize them. I want to recognize Dr. Claire Omasheye. She's the president, West African Private Healthcare Federation. Dr. Claire, we are sure you are still online, and we'll also give you the opportunity to give your goodwill message after this photo shoot. I also want to recognize the following people. They've been online since morning. I'm recognizing our medical elder in public health, Professor Tanimola Akonde. I want to recognize the President of the Director General of the Hospital Management Bureau, Kwara State, Mr. Ladisaad Aluko. I'm recognizing the presence of Dr. Ekpeyong Ekanem. He is the M&N advisor for APT Associates Global. We also recognize the presence of Dr. Jimlas Ogunshaki. He is the special advisor to the Executive Governor of Ekiti State on Health. And we also recognize all our colleagues from Farm Access Foundation within Nigeria, Ghana, Tanzania, and of course from our head office in the Netherlands. And surely we also recognize all our colleagues from the Nigerian Health Watch. So permit me to call on Dr. Claire Omasheye to give her a goodwill message. Dr. Claire Omasheye, are you still online, ma? Okay, so if I can't confirm Dr. Claire is still online, right about now, we are moving towards the end of the program. But before then, I'm going to call on my country director again. Okay, thank you, Somto. Somto just told me now that Dr. Lumide is online. Dr.
I am
Lumide,
here.
you are supposed to give us the next steps and like a closing remark. So, Dr. Lumide, you're online?
Yes, I am. I don't know if you can hear me.
Thank you, sir. You are welcome again.
Yes, but I don't know if in Jide, because there's a need for us not to make this another talk shop. I think it's important to leave this venue with very clear, actionable steps. And I don't know if Njide wants to outline some of that so that before I then put my own.
All right, she'll come up now. Thank you.
Look, speaking to colleagues on this call, both virtually and physically, what the DG budget said, I think needs us to go back to the drawing board. What he is saying in brief is that he cannot guarantee earmark. That is what he has said. And I think we need to develop a strategy to make that happen. Back to you, Njide.
All right, so Dr. Olumide, you can go ahead. Njide will conclude once you finish. Thank you.
Okay, fine. So, sorry, I think in summary, just to mention that it's clear to all and sundry that Nigeria Health Outcomes is a reflection of the amount of financing that we're spending and is also available. So we need to see how, one, we can get more money into the sector, and secondly, to see how we can use the money that's allocated to us in a better way. So how can we get value for whatever has been allocated to the sector? And I think Senator Loriegbe really emphasized that when he indicated that our sector even returned money, even in an environment where there's little money. The second point I would like to emphasize, especially as we begin our advocacy, is do not let's stick to only sugar-sweetened beverages taxes. Pro-health taxes are a triad. They're alcohol, tobacco, and sugar-sweetened beverages. It is the three that made a difference for Philippines. So please don't let's just focus solely in our advocacy efforts on sugar-sweetened beverage taxes. And to say the next one will be the two things needs to happen in that conversation. The government of Nigeria had committed to having a gradual increase, phased increase in alcohol and tobacco taxes so that more money will be in the pot. That is on pause now. So our advocacy should include reintroduction of the gradual phasing of the increase in alcohol and tobacco taxes. Second, the sugar-sweetened beverages now are too low to be a deterrent. It should be increased. The other point is, because too little money is being spent on health, and again, everyone has emphasized this, the health sector is different from other countries that do not earmark. Without this earmark to health specifically, the number of Nigerians who are being impoverished because of catastrophic healthcare will rise. So we need this additional financing. And my last point, I would like to reiterate what Nkata had said and even other speakers had said. We need to move towards an outcome-oriented framework. Now, the new NHIA Act is in 4 parts. It defines the Vulnerable Group Fund as number 1, NHIS BHCPF, special intervention fund, health insurance levies raised by the NHIA, and I would like to add that the pro-health taxes or the SSB taxes should come into this pot. That way, if the totality of these funds comes to 60 billion naira, government in January of the year will say, this translates to X million of people. That is the most important accountability framework. And these are the kind of things that we can use to convince DG budget that the health sector is not frivolous, that the kind of reforms that was made by the Ministry of Health, if this approach is taken, it will not happen again. Thank you so much. It's been such a pleasure being here, but I believe that we need to, over the next 2 to 4 weeks, before the budget is finalized, because the money from the SSB taxes is already coming into the revenue, into the federation account. But like the DG budget said, they are not keen on giving it to the health sector. But the health sector played a leading role in ensuring that we were able to counter the industry. And I think in response to that, the Minister of Finance and Budget and Planning should recognize what the health sector has done. And several, I think Dr. Pamela Ajayi and several other stakeholder activists mentioned the role that they played. So please, we cannot let our all rest now. This is the time to push on. Njide, over to you.
Thank you so much, Dr. Olumide. Really great place to end the conversation right there. So I'd like to make welcome Dr. Njide Ndidi for her final remarks.
Wow, it's been a fantastic day. But before I close, I wanted to give one of our anchor states, Dr. Olubumi Winters, has been sitting with us all day. She's the executive secretary of the Kwara State Health Insurance Agency. And ultimately, she will be one of the implementers when this money actually does get to the state to apply some of the funds. So, Dr. Winters, if you can just reflect very quickly before I close on what you've been hearing today and the example this will set for the state.
Good afternoon, everyone, and thanks for all the panelists. It has been really engaging. I think my own takeaway from here today is how we begin to sell the tangibility of the health services that we provide, and looking at the framework being done in a holistic way from where the funds are coming from right down to the facilities that are funded. And this should be data-driven. Based on outcomes. We have, is it improvement in health indices, reduction of catastrophic health expenditure, things like that that can sell health sector to the people who we're trying to engage to earmark these funds solely for the health sector. Until we begin to see the tangibility in the health sector, I don't think we'll be able to make a case. I also want to look at the way even state governors look at healthcare expenditure, balancing the supply side and the demand side. For an average governor, he wants to see very big structures that he has built, hospitals, healthcare centers, diagnostic centers, but not minding who is going to access those centers and how we can begin to support people or subsidize healthcare services so that people can really access these centers. So I still think along those lines that where are priorities and how do we sell the tangibility in healthcare expenditure such that we can showcase what we have done even at the implementation stage. Thank you.
So we've come to the end of this really important dialogue. And I think that I don't really need to reiterate the summaries that the panelists, the moderators have given, as well as Olumide. I think he made some really important closing remarks. So first of all, he asked about what the next steps are. I think that there is a lot to be done within the next 2 weeks. So I will pull back on the team that have done a fantastic job, the World Bank team, the Nigeria Health Watch team, and of course the Farm Access team who have coordinated this program. The first step for us, of course supported by the Healthcare Federation of Nigeria and DGI Consult, I think these 5 entities have the task of filtering through all the robust discussions today and the tangible points that have been made, quite a lot of them. We need to develop a communique, and we need to make sure that the communique gets to the relevant people. I was discussing very briefly with the DG of the National Health Insurance Authority, and he's really excited. You know, he said we have started the work that he's been hoping to do, which is to get more money into the healthcare sector. But from this communique, I mean, there were so many important, points that were made. One of which is that from Dr. Eke, I must say, that there is already a pathway. There's a basic healthcare provision fund which can implement some of the funding that is already coming into the scheme through the state-supported health insurance program. And so many others. We had the problems from the Cancer Health Fund and how difficult it is to even implement that. I know when we were driving that through the Healthcare Federation and when we got that passed, but I'm even shocked to hear that it took 2 years before it was actually being disbursed. So there's quite a number of really important points that we need to, filter and put it into a very, very discreet and pointed communique that must get to all the sectors, to all the important people, finance, health, and so on, and then we begin to push it. The DG...
Hello, Njide.
Yes.
My apologies for breaking in. Dr. Chris Isokowun, who is the director of the BHCPF Secretariat, has insisted he needs to make a comment. Please, apologies for breaking this protocol. He's a major stakeholder. If Dr. Chris is still online, Njide, please, can you kindly allow him to just to very briefly reflect, if it's okay with you? My apologies.
Okay, is he online?
Yes, Dr. Chris Isokowun, please let me, he just sent me a message.
Okay, so he's not
yes,
yet...
he's online. Dr. Chris is online, but maybe as soon as he's ready, please continue. He just is an important stakeholder and we do acknowledge his participation and presence. I will let you know before you end, please.
Okay, so that is the important next step that needs to happen. So once that is done, and we'll make sure that all the different partners have a chance to, okay, he's online now, to look through that communique before we share it. I understand he's online now. Is that correct? Okay, so can he go ahead? Brief comments, because I'm sure.
Yeah. This is good afternoon, ladies and gentlemen. This is Dr. Chris. Do I
put
have
on your video? Yes, you do. Put on your video, sir.
Thank you very much, Dr. Olumide. I want to thank everybody for a very well-organized dialogue. And I'm really happy to have been part of it. I've been at this dialogue since the beginning. I just wanted to mention the fact that the Basic Healthcare Provision Fund is a very critical component of healthcare financing and a major step by government to address the financial gaps. But it's important to correct the misconception that the Basic Healthcare Fund is lying down unspent. I thought I should correct that. Disbursements have been made, states are implementing. Funds are being disbursed to health facilities on the NPA-CDA gateway. Over 1.01 million people have been enrolled under the NHIS gateway, out of which a little over 750,000 are currently accessing care. Premium is being paid for each of those enrollees. And we were waiting for feedback from the states. Now, we cannot disburse funds to states when they have not accounted for, they've not exhausted the funds that are in their possession. So when you look at the Basic Healthcare Provision Fund account and you see some money in the account, doesn't mean that it's lying there, we do not have the capacity to spend it. But one of the very important components of this fund, as we've been in the new guideline and operation, is to ensure accountability and transparency. So pushing funds to states, and like Dr. Onkata talked about, by funding input rather than output and outcome is counterproductive. So we send funds to the states, we purchase services, we want to get feedback on what they have done with it, and then we can now send more funds. The fund that we had in 2021, first of all, disbursement was made in 2018 appropriation, and then in 2021. Since 2021, it has become statutory. And all of the funds that was released in 2021 has been pushed out to the states. And we cannot push out more if the states have not at least spent most of their funds. And most of the states are yet to spend up to 50% of the funds because the money that was sent to them was for the whole year. However, we are looking at the performance of the states for further disbursements. And as soon as the MOC meets, the Ministerial Oversight Committee meets, and they are meeting in a couple of weeks, funding will be released to states that have the capacity to exhaust their funds. And what I mean is, for example, if you give a state a target of 100 enrollees, and the state has only been able to enroll 80, you cannot send funds again for further enrollees. But if you gave a state a target of 100 enrollees and they've enrolled all 100, then it means they have the capacity to enroll more. And such states will be given further funding. But we must also be mindful of the fact that if you exhaust all your funds and you register more for now, because that's what your funds can take.
Did we lose?
So anyway, thank you all again very much. Just to say that the most important priority of the Federal Ministry of Health is to ensure transparency and accountability in the use of the Basic Healthcare Provision Fund. And we'll continue to work with our partners, all of you seated there, to ensure that the funds reach out to the poor and indigent Nigerians for which the funds have been targeted. I am looking forward to further deliberations and discussions, and we'll continue to partner with the Health Watch, Nigerian Health Watch, to realize our objectives. Thank you so much.
Thank you so much, Dr. Chris, for that clarification. I think it's important that he clarified that. Again, the BHCPF has the capacity to actually transform healthcare or health insurance for the indigents and low-income communities. So I'm very happy he clarified that. Again, this is also an opportunity to see how this SSB tax or pro-health tax can also support the Basic Healthcare Provision Fund. So having said that, I think we've pretty much come to the end of this dialogue. But before we close, I really would like to, recognize all the different players, all the different teams, the panelists, the moderators, my colleague from Ghana, Dr. Maxwell. I think we need a copy of your speech. I hope it was written somewhere, because that is really a fantastic lessons learned and experience on how we can possibly tailor implementation to model against Ghana. I mean, Ghana being at 56%, you said, and Nigeria, I think in terms of coverage, we're still at maybe 5%, 3%. We don't even know what the actual figure is. So again, also to thank Sonia, I think she has left, who is the representative from the Consulate of the Kingdom of the Netherlands. Without them, we probably won't be here in terms of farm access and the support that we're giving to Nigeria, both at the federal and the state level. The Healthcare Federation, I don't know if Pamela is still online, but again, we, at the very beginning, we're advocating for the implementation of this tax, and now it's been implemented. So the advocacy continues to ring fence it and make sure it doesn't move into the melting pot like Maxwell had talked about, and that it has an identity and we can tailor where it goes to. So again, just to say thank you to everyone. Thank you to the teams that organized this. We didn't have too many technical glitches. Thank you to all the participants, but those online, I can't see, I would have maybe mentioned a few, but we recognize that you're there, and we appreciate the fact that you've stayed from morning up until now. Claire had sent me a message that she wanted to also chip in on behalf of the West Africa Healthcare Federation, but I don't know if she's still online. Vivian, I don't know if you're also still online. Thank you very much for the support and the collaboration. I don't know who I haven't mentioned, but again, to all of you who are here, those who are all online, the Farm Access team, thank you for the phenomenal work that we're doing. So I'll hand back over to Kemi Somto, I don't know who. Thank you.
Yes, thank you so much, Njide, for that wonderful remark. And once again, we thank all invitees. Thank you so much for honoring our invitation. We're excited about the conversations and the outcomes of this dialogue. And just like Olumide has mentioned, the outcomes and the outputs from this dialogue, we'll have to, synthesize it, produce the communique, the reports, and all relevant documents, so that we could actually, move into action and achieve all that has been agreed in today's conversation. So once again, thank you, and we look forward to a 2.20 of this conversation, hopefully in the next 6 months or sometime next year, to assess where we have, what we have achieved, so far. So we'll move from here to have group pictures, and after the group pictures, we'll move down for lunch downstairs. And also thanking our online audience. Thank you so much for sticking with us. The numbers didn't drop. Even when we went on a long trip break, you stayed with us. Thank you so much. And then we'll look forward to the next policy dialogue. Thank you all. Welcome.
Use this opportunity on behalf of my classmates or my classmates to thank the Enterprise Development Center as well as Farm Access for giving us the opportunity to go through the healthcare management program. And I want to thank them for actually coming up with this program, its design and its sustenance, because it has had a lot of impact in all our lives, and we believe ultimately in the life of the country as time goes forward.
Please, can we move forward for the photo shoot? Julia, please, your attention is needed there. Thank you.
Particularly in the era of COVID, change management process is one of the things that has to, be a key part of any business process at this time, particularly in the health sector where, unfortunately there's a lot, well, maybe fortunately I should say, there's a lot of focus and light on healthcare sector, and so change management process has to be one of the key modules that one has to embody in whatever sector you're in and in whatever space. So for me,
Dr.
personally,
Winter,
as
Dr.
a
Gafar,
medical director,
Mrs.
I'm
Alawade,
using a lot of the things I've learned in class
Kemi,
to be able to change processes in my organization without disrupting function, and at the end of the day, improving service delivery.
Serrano, please can you move forward? Dr. Taye.
Quality healthcare is a luxury that a large portion of Nigeria's population can't afford. This is Mama Dami, a middle-aged single mother with a health emergency on her hands. At the hospital, she learns that because she has no insurance, she may not get the medical attention that she now desperately needs.
Just give her something, at least to stop the pain. Then I'll run around and look for the money, please.
Her cries for help gets her some support, but it is not enough. This is the story of millions of Nigerians who die every year because they cannot afford quality health care. But what if we could rewrite this story?
Are you registered with the health insurance program under this hospital?
Yes.
At Farm Access Nigeria, our vision is a Nigeria where anyone, regardless of their economic status, has access to affordable and better health care for themselves and their families. So Mama Dami does not have to panic when her child falls ill. All she needs to do is to go to a facility where she can get the best attention. And because she has health insurance, she is certain that her daughter will be attended to almost immediately. Quality healthcare is not a luxury, it is a necessity. And with a token per year, every Nigerian, regardless of their socioeconomic status, can have access to the best healthcare available through health insurance.
I'm Dr. Olaiwola Bello, the Medical Director of Sugar Hospital. But I think the journey with Farm Access Foundation started about 2011 when there was a program called Idea Community Healthcare Program.
Farm Access Foundation introduced a community-based health insurance scheme in Nigeria as a way to test the paradigm of how people purchase healthcare for themselves. And at the time, we started with the Lagos market women and the farming community in Shonga, Kwara State. Sobo was selected as one of the providers on that scheme. And at the time, to be honest, one of our efforts was to make sure that the quality of service within each of the provider hospitals was improved. And so we introduced Safe Care to all the providers that were going to be providing care in that program. So that's how Subo was introduced to Farm Access.
So what they required of us were basic safe care standards that we needed to put in place. and we were able to put that in place within 6 months of our first encounter with pharmacists. If not for safe care, I'm very sure I wouldn't be where we are today. We won't be where we are today. It's been very interesting, and it actually opened us to what quality is all about in medical practice.
So Farm Access Foundation, really, our focus is to improve access to quality healthcare services. And we found that over the years that it's not just about improving healthcare financing from the patient side, but it must at the same time simultaneously improve the quality of care from the side of the hospitals. As Farm Access, we teamed up with JCI, which is Joint Commission International, the accrediting body for healthcare facilities based out of the United States, as well as COSASA, which is the counterpart in South Africa, to come up with a set of standards, especially for resource-restricted countries such as Nigeria, that allows hospitals to improve their quality without, spending way too much money, but just the basic quality improvement as a stepping stone to international accreditation. So basically, it's not a fail or pass process, but rather is a stepwise improvement to quality. At level 1, there are a set of standards that you need to, implement for you to move on to level 2, and so on to level 3, all the way to level 5. So this is a process that we started over 10 years ago to move hospitals onto a better quality improvement